Bore da chi gyd, a croeso I bwrdd iechyd Prifysgol Aneurin. Welcome to the Health Board and the meeting today. Could I please confirm that the meeting is being held in public and members of the public are able to observe in person and online, and welcome to you all. Could I remind the board members that the chat facility is not to be used during this meeting and that all comments should be made in person, if that is at all possible, and raised verbally. Before I make a start with the business of this meeting, could I just remind us all that this will be the last formal board meeting of Dr. Sarah Aitken, our Director of Public Health. We will have an opportunity to say goodbye, adios and farewell to Sarah at our board development meeting in December, but I would just like to acknowledge the enormous contribution that she has made to this organisation since she became the Director of Public Health 6 years ago, and has pushed us on gainfully to new heights, and certainly did an absolutely brilliant job during the COVID pandemic, and thank you. But we will be more full at the board development session. This will also be the final meeting of Keith Sutcliffe, who that is online, as the chair of the Stakeholder Reference Group. Keith, as a token of our appreciation for everything you've done for us and for you being so persistent and excellent in terms of signing into us throughout the pandemic and not losing track of what we were trying to do. A token of our appreciation for your efforts will be delivered to you, and I hope you enjoy. And thank you so much for your commitment to the board over the last few years, and all the best for the future. So many thanks.
Thank you very much. It's been my pleasure.
Good. Thank you very much indeed. We'll be joined by a number of guests throughout this meeting today, and we'll introduce them at the relevant item on the agenda. Finally, could I welcome Rob Holcomb to his first formal meeting as the newly appointed Director of Finance, and could I advise the board we have appointed Tracy Daskovich as the new Director of Public Health, and we will look forward to meeting her in the very near future. So thank you. Thank you. Apologies for absence, for noting. We have apologies from Peter Carr and Shelley Boston. I know that Richard and Paul have to leave at about 1 o'clock, and that Leanne has to bounce out at what time is it? 10 o'clock. 10 o'clock, and I have to go for an urgent meeting with Welsh Government at 12, but I will leave the board in the capable hands of Pippa during that time and hope I won't be long. We'll see what happens. So there will be a bit of toing and froing, but I know that you will continue to invest your energies in questioning, as you usually do. Are there any declarations of interest? No? Okay, thank you. The draft minutes of the Health Board meeting held on the 28th of September, are they a correct record? Thank you. Thank you, David. And the summary of the board business held in committee on the 28th, we have provided an overview for noting. Is that accepted?
Yes.
Thank you. The action log for review, Rani.
Thanks, Chair. So the action log includes 5 actions from previous meetings, all of which have now been completed, as noted in the paper for the board's update.
Thank you. Any comments, any questions? Anything we haven't picked up? Okay. On to 1.7.
Thanks, Chair. So this paper provides the board with an overview of the use of Chair's action and the application of the Health Board's Common Seal for the period 14th of September to 14th of November 2022. During this time, there has been one document that required a sealing, and that was in respect of the YYF breast unit. And in addition to that, there have been 4 matters agreed by the use of Chair's action during this time, and they are set out within the paper. The board is therefore asked to ratify the use of Chair's action and the use of the common seal during that period.
Is that accepted?
Yes.
Yes? Thank you. 1.8, report from the chair. Just briefly, as you know, I have bilaterals with every member of the board every month, and those have been continuing. I've also attended a number of other meetings, namely the Gwent PSB, where the Marmot proposals were discussed and endorsed, and that was very much thanks to the driving force of Sarah. I've met the local authority leaders on 2 occasions during the month. I usually meet them fortnightly, but it's been monthly for the last 2 months, where we've discussed the general situation and the issues of homelessness, the cost of living crisis, and other things that affect our communities as a whole and how we work better together as a collective. I have been to the Regional Partnership Board Leadership Forum twice, partly because we had a meeting with the Minister, so we needed obviously to prepare and agree the priorities we would wish to discuss with the Minister, which we did, which included workforce issues, and we've had many discussions about the workforce issues in this forum. The eliminate profit from children's services in social care, and the issues surrounding that. The tapering of the Regional Partnership Board Regional Investment Fund monies over the next few years, and an issue about the joining up of the policy statements within Welsh Government and how best we can take those forward. The Minister listened well to what we had to say, and we had a purposeful and useful discussion about that. I've also met Sean Morgan, who is the leader of Caerphilly, who has also been elected as the Gwent Public Service Board Chair, to ensure that as Chair of the RPB, that he and I work in partnership and do not duplicate the work of the 2 individual committees, but make sure that we are synergistic and use our facilities and our services and our staff in the best possible way to meet both the objectives of those important committees. I've also had a meeting of the chairs peer group, chairs of health boards and health bodies in Wales, and the things that we discussed were the objectives set by the Minister for the chairs and how they could relate well with each other, because we are a collective after all. Urgent and emergency care, as you might expect. Social care and the issues arising from the difficulties being faced in social care with workforce as well. Appointments to health boards we discussed, and the governance of health boards, and the NHS executive establishment, which is supposed to go into shadow form on the 1st of January, but we do have our concerns about the huge amount of work that has to be undertaken and agreed before we get there. So we have written to Judith to advise her about what we feel about that. We've also had a meeting of chairs and chief executives with the Minister last week, at which we discussed a number of very, very significant issues. But prior to that meeting, the chairs and the chief executives of the health bodies had met to pen a letter to the Minister outlining the situation as we saw it collectively, the priorities that we believe we must pursue, which is valuing our staff and valuing our patients and their services, and the whole issue of the downward pressure of the cost of living effects on our population and their health and well-being. So the sorts of things that are anyway highlighted in our IMTP. We had a good and positive meeting with the Minister, who was at pains to thank the staff for their continuing efforts, particularly under such stresses and strains as we are feeling now. She was obviously concerned about the budget settlement and the substantial challenges that would face us, together with the workforce issues. So she has said, she thanked us very much for our letter, that she's going to be very clear about the requirements placed on health bodies over this next 2 years. And she would wish to concentrate on 6 or 7 main priorities, and they're really not ones that you would not expect, such as delayed transport. What more can we do? So we have agreed as a collective to write to her next week to outline the ideas we have about what more can be done and what help government could provide, which we felt was a constructive way forward that she welcomed. We discussed the winter pressures, and she has called subsequently an A&E, an ambulance, what was it called? Summit, summit with the leaders of the executive leadership of the health boards 2 days ago to discuss that further with them and the clinicians concerned. So we had a fairly good discussion about digital and the fact that actually progress will be slower unless we sort out the digital platforms and the advanced practices that we have been talking about for such a long time, and which are being implemented throughout Wales as pilots. So we are all keen to ensure that we pursue the digital agenda effectively as a collective. We've also been this week, this last couple of weeks, totally absorbed as well by the interviews, and I'm so glad that we have been successful in our new executive appointments. We had a very good field, and the interviews were very rigorous. So anybody who survived them must be worth a go, I think. So that is my very brief overview of what I've been up to. If anybody has any questions, queries. No, thank you. Chief Executive's report.
Yeah, thanks, Chair. So just a few areas to kind of highlight that I think is worth mentioning. First of all, around the financial challenge, we agreed at the last meeting that we would be declaring a deficit in parallel with the month 6 monitoring returns. So I did submit an accountable officer letter, which I shared with board members, which has been acknowledged back from the Director General and Chief Exec of NHS Wales, acknowledging the letter, disappointed with the position we're in, given our submitted and approved IMTP, which was predicted financial balance, that does acknowledge many of the pressures that we've set out, but with an expectation that we continue to push as hard as we can in terms of improving on that position, but with a really clear brief that we need to absolutely ensure we don't go above that level, given the impact that then has on the whole of NHS Wales finance. So some helpful points, and also trying to draw out where there's some learning that we can take in terms of where we might be out of line with other health boards in terms of our expenditure trends. So Rob and I are picking up some of the issues within that letter, but I think I shared the response background to both items as well. I thought it's worth probably mentioning the Grange University Hospital, and continues to be under the spotlight. We had myself, James and Leanne had a really helpful meeting with MP and MSs, sharing the evidence that we've done through the previous reports and some of the work that we've got underway in terms of trying to improve the situation, but sharing the positive data in terms of clinical data that's showing improved mortality in some of the outcomes, but also recognising where patient experience is particularly challenging at the minute, but also trying to demonstrate that it is actually facing the same challenges as all other health boards, and it's not an exception. In fact, it's generally in the top 3 of the 6 main health boards, albeit none of it is where we would want to be. But we thought that was an important session, and they welcomed that. And I think that's an approach we might take with further kind of deep dives into primary care and social care in future sessions. Obviously, a few weeks later, we had the Health Inspectorate Wales report around the Grange, which, whilst I don't think we disputed anything that was included in the report, it didn't, we felt, capture some of the positive feedback that was given to the teams that was in the report, particularly around patient monitoring and safety and best practice in Wales, which I think we also heard at the board meeting last time when they attended. So we've tried to be really kind of balanced in our media responses to make sure that the public did actually, pick up on some of those kind of more positive elements of the report, as well as the areas which we don't dispute need to be improved. And on that note, we've been making some good progress around the ED waiting room, which is a strong theme in the report around it. The amount of people now attending means the waiting room isn't fit for purpose, and I think we all acknowledge that. So we've now working closely with Welsh Government, and we're hoping that the plans will enable us to secure additional funding for us to build a bigger waiting room that will be attached to the building. It will take us probably 12 to 18 months, but we're working hard on that. And I've definitely made progress since the last meeting in terms of securing funding for the design room. To the end,
Can I ask, why was there a disconnect between the briefing we received from Health Inspectorate Wales compared to the actual press release that went out? Because the information we got seemed to indicate a certain direction of travel. The press release, I thought, was incredibly unhelpful because it then gave a different message to the public that we hadn't been briefed on as such. And what information is provided to the health board prior to any press releases, and is it confirmed and looked at and considered so that we're able to give a considered response in response to what they provided? I thought it was incredibly unhelpful, and I think that whilst we recognise the work and role of the Health Inspectorate at Wales, from my perspective as the health board, we also expect openness and transparency in terms of messaging, and I think it's absolutely vitally important that they have some sort of mechanism in place to ensure that if there are messages going out, that we are not ambushed in any way, because I felt it was unhelpful.
Yeah, no, thanks, Paul. And I did have a conversation with HMW, but very respectful of their regulator role and their need to maintain complete independence. But I did just feedback that we did feel that maybe we didn't disagree with the contents of the report and some of the findings, but the positive findings which were fed back weren't as kind of strong in the report as it was with the negative elements. And I just think it's important for the public to be worried where they should be worried and reassured where they should be reassured. Yes. And I think some of the patient, because I think what we see is that when we manage risk appropriately is what the feedback was telling us in terms of safety, but that means those that less at risk wait an inordinate amount of time, which is not acceptable, and therefore patient experience is not in anywhere where we want it to be. But I think the patient safety bit wasn't as strong unless you went deep into the report. It did acknowledge the hard work of the staff and the positive feedback that the staff received. That was really clear in the press release. So I think it was the patient safety, which I think as the members of the public, that's an important message to have alongside that poor experience. So we fed back. I think, we have to be respectful of regulators. We don't see the press release in advance, but we tried to make sure we were very balanced and fair in our response to that media. And also just in terms of making sure our staff are supported during very difficult media attention. I just felt it was important to highlight that it was something, and we are working really hard on trying to make sure people are appropriately informed with the positives and the negatives, and the work we're doing to try to address those issues.
I think it's probably worth us considering, and to Paul's point about the stronger relationships with, for example, the Argus of Wales Online, so that if they have the kind of relationship where they can pick up the phone and say, we've got this story, and is there anything that you would like to say or comment, or I think we already do have some really good relationships, but it may be worth just touching base with them to see whether or not there's any way in which we can improve them further.
Well, thanks, Bevan. And we will pick it up, but we have the comms team have got really good relationships. Yeah, they are they were very balanced in their reporting, in all fairness. And I do think some of the media coverage was, some were more balanced than others, but I did think it recognised this was a system-wide issue, not just the Grange, but therefore working with our community as much as possible and sharing information, working with our PMS is really important so that they get the whole picture. That's what's really important.
Could I just make another comment?
James and then Jen.
I mean, one very important thing that was fed back to us by the inspectors that didn't make it into the report really was that they felt that the department was very calm and well led. And then they went on to make the point that they would happily bring their family members here. And I think that is probably the most reassuring accolade from the inspectors. And that's why I was very disappointed by the headline that was in the press release, exactly as you said. But actually, once you went down into the detail, it was quite a long way down. They did acknowledge the quality of services being provided. And, you know, we fully acknowledge that the waiting room is not adequate, and we are working actively as hard as we can to fix that.
And I did want to pay tribute to the comms team, actually, because I think that the information in the Argus particularly, I think, was indicative of a very good working relationship with the local media. I mean, it's disappointing that the report isn't embargoed, for example, within for 24 hours by the inspectors, so people can actually, particularly organisations, have an opportunity to look at it and put a considered response out in the media. And I just think that I hope that there'll be reflection by Health Inspector of Wales over this to make sure that in future there is a proper protocol in place to ensure that there's no public sort of worries or concerns, which really I think were unnecessarily hyped up as a result of that headline.
Jenny?
Just very briefly to say that I have raised it with our relationship manager with HIW. I've had a very strong conversation with him around public confidence, the impact that that has on patient safety. There's definitely been a shift in England in terms of the way in which regulators report services, so it doesn't lose public confidence, because I think that introduces a safety issue if the public don't have confidence in our services. So I have raised it with him. He has taken it on board, and they are discussing it internally in terms of their communication pathway. Because I think the timing was also, I think we had 24 hours to look at press release. You would expect to have a few days to be able to consider a response in a very considered way. So I have raised it with him as well. Thank you.
Okay, thank you. So we've had a number of system leadership sessions in the last few months. This is taken a much wider meetings with our senior leaders, firstly focusing on managing system risk in the context with which we work in, and some of further opportunities we think we've got ahead of winter. And we had a recent one last week, particularly looking ahead into 23-24, given the challenge we know we're going to face, with the continued workforce challenges and the financial outlook, cost of living and so on. And really trying to think about a new way of working across the organisation, and really trying to work collectively at all levels of the organisation, and making sure all staff are feeling more empowered to contribute to the challenge we're going to face. So that's moving forward. Regional planning, we're making some good progress. We had a really useful workshop on Monday with all representatives from all the health boards, the chief executives, chairs, medical directors, and crews. And I think orthopaedics, ophthalmology and diagnostics were represented by the clinical body as well, trying to get that kind of clinical commitment and senior leadership commitment to really working differently, particularly with the backlogs of patients we've got across those three areas. And in terms of ophthalmology, we have been successful in securing till the end of March an extra capacity at the Cardiff kind of temporary facility, which will be equally shared between Contact Morgana ourselves and Cardiff, which I think is a step in the right direction of us working together. But lots of ideas, and I felt there was a shift in the commitment. The chair's referenced the progress of the executive director appointments, which I'm really, really pleased about. And we've now got the director partnerships out to Antwerp with the director of digital and progressing not far behind it as well. So that's really positive. I just wanted to pick up that I have been trying to prioritise the last few months to get out and about into the organisation. It is the most insightful and rewarding part of the job, and continue to be really humbled by and excited actually by the enthusiasm and hard work of the teams out there who really do want to make a difference. So myself and the executive team are making a commitment that we all get going somewhere at least once a week. The comms team have recently done a communication survey for me, just in terms of what do people find the most effective ways to communicate, whether that's newsletters, kind of Facebook or whatever, different options. But the strong, as much as they like some of those methods, they all want visibility and they want people to be seen. So I think it's a big organisation to get around, but we really are committed becoming more visible, and not just us, but all of the senior managers across the organisation. So we are also following up with staff who don't have access to email in terms of how do they find the best ways to communicate as well. So we've done the email version, going out onto the floor to get further updates. And just on a positive note, there's been a huge amount of staff recognition in the last few months through staff awards. I think a couple was worth mentioning. At the Care Forum Wales Awards, we were recognised as the best health board supporting care homes for COVID-19 heroes category, which I think was a hugely significant recognition, particularly over supporting care homes with vaccination programme and other areas. The National RCN Awards, we won the Nursing Support Worker Awards through the Recovery Through Sport programme. And this is where we got 2 healthcare support workers who have set up a all-inclusive sports programme for particularly people with mental illness. And that is really being recognised and is hugely promoted. And I'm looking at ways in which we can get some of the award winners to a board briefing or board development sessions for you to have the opportunity to listen to some of the work they've done. The Health and Care Awards, we had a number of winners there. The peer support, the peer mentor development team, they are kind of close to my heart at the minute, but it's quite a newish project, Chris, isn't it, where we've employed a number of staff who have suffered with mental health issues themselves. They are now peer mentors to patients who are currently suffering with mental health, and it's been hugely successful in terms of how people can relate to these members of staff. And I think it's something we really should explore further and celebrate. And I would love you to hear a bit more about that through some of those sessions. The NHS Wales Awards, we had 5 finalists in there, and we had one winner, which was the Bespoke Repatriation Service, where working with the third sector, United Welsh Housing, where we're supporting specialist mental health patients trying to get back into independent living from facilities in England. We also had recognition for arts, organisation development team, the Cardiac Rehab Value Project, Practice Assess and Garvo Awards, and we had a number of individuals, including Bevan around infection control, inspirational women, around the lung cancer nurse, and Janet Clay, who works at the Grange, who's worked 52 years for the Health Board and 49 as an ED nurse, which is quite incredible, and currently doing a lot on bereavement work as well, so she was outstanding. So I thought it was worth sharing some of those positive, and what we've done is put a briefing to all of the award winners, what they won the awards for, and we tried to get some of them showcased into at the end of the board development session for some you to see some of that. So the next few months I'll be concentrating with the executive team on winter resilience and risk management, so also going to be a difficult few months, I've no doubt. Financial delivery is going to be key, and really preparing for 23-24, and for me is trying to instill a new way of working as we go into the new year, and increased visibility and communication, and really focus on retaining our staff, recruiting staff and looking after them. And just as a little bit of a promotion, we've got Project Wingman that's underway for the next 4 weeks. This is the double-decker bus that is spending a week at each of our main sites, which we've got staff from some of the Air Force industry, and people can go on the staff can go on the bus, they can have coffee and some snacks. We've got therapy dogs on there, sometimes a bit of massage, and the staff have loved it when we tried it last time, and the team in mental health have been leading that. So I'm hoping to get up to Neville Hall one day in the next couple of days, because it's there this week. So I just, if we share around where the actual bus is, then if any of you want the opportunity to go and visit it and have a chat with staff, then it could be a really good opportunity. So thank you very much. Thank you very much, Nicola. Any questions to Nicola? You've been awfully busy.
Thank you so much, and we can tell the galvanising effort that you've made with these things and how everybody has really grown in the last few months. It's really good. Well done. Keep going. Okay. On to patient experience and public engagement, and a report from the Aneurin Bevan Community Health Council. Gemma.
Thank you, Chair. Morning, everybody. I'm pleased to share my report with you again. And I just wish to offer a correction at the start on page 7 at the top of our visit to the ED. There is an incorrect timing issue. At the first bullet point where it says that a patient had reported that there weren't any doctors available between 2 a.m. and 8 p.m. There should be 8 a.m. was the feedback we received on that day. So my apologies for the typing error in that report. In terms of my overall report, I don't really have anything further to add other than what Nicola has discussed under Chief Executive's report, because the whole system pressures are still apparent. There's still significant concerns for the CHC and for people accessing services across the system. And by the whole system, just for clarity for public, we mean the whole health and social care system and not just health. So as a CHC, we nationally recognise that the pressures are being seen everywhere and isn't just isolated to the Aneurin Bevan area, but the pressures still continue. But we do want to give absolute recognition to the fact that all the staff within the system are a credit to the NHS. They're working so tirelessly in a really difficult situation. It's seen when we do our visits. Our members on visiting teams do see that the staff are providing the highest levels of care that they can in the circumstances, but always need to bring it back to the patient experience, which is difficult at the moment. And we are still hearing of very long waits in the waiting area for both children and adults now. We have started to have some feedback that some waits for children in the children's assessment unit can be a little bit difficult overnight. But it's the stories in the community that we hear the most about in relation to people waiting for ambulance, whether they're a green call or one of the amber calls. So we know that they're waiting a significant amount of time if there are delayed handovers to the ED. And CHCs across Wales have recognised this as a national problem ahead of winter, and we've taken steps as a collective movement to make the necessary referral to HIW on the Welsh Ambulance Services ability to meet the needs of the community at the moment. So we've taken a national step on that front. In terms of our other activities at the moment, you can see from our report that we did our very first visit to the SDEC, your same day emergency care unit at the Grange, which members were very impressed with, and all of the feedback from patients was that they felt the unit was well managed, calm, safe, and that people were seen in a really quick and timely manner, which is really lovely for us to offer that positive feedback. We were in the unit on the day of the 17th of October when the Grange did see unprecedented levels of attendances to the ED. It was difficult for our members to observe the waiting, but you've already acknowledged that the waiting room isn't fit for purpose and that you have plans in place to make a permanent extension to that waiting area. Because largely the patient experience does come down to the wait. The feedback that we get is that the clinical care is excellent and people aren't feeding back to us that clinical care is part of the issue that they wish to raise with us. We've got three projects open at the moment. We have our post-COVID syndrome briefing, our common ailments service survey, and our sensory impairment survey. And I'm happy to take any questions from the board about any other elements of my report.
Thank you very much, Gemma. And once again, thank you and your team and your volunteers for the huge amount of work that you do, which really, really helps to inform our policies and practices going forward. We all acknowledge the extraordinarily difficult experiences within the A&E department in terms of waiting and indeed signposting, because we have changed the system at the moment, and I know a number of people have had difficulties in finding the way in, basically, so that has to be put right immediately, and thank you for that. Are there any questions or comments to Gemma? Paul, Pippa and Nicola?
First of all, to say a huge thanks to Gemma. I think that the Community Health Council does an excellent job there. I noticed your report on stroke survivors and you were looking to get a report in, I think, by the end of the year. I just wondered if you can just brief us on the next 6 months Your organisation will end at the end of March. A new organisation then commences at the beginning of April. We've got to make sure and ensure that patient voice is maintained throughout. So what, it may not be for now, but it may be, we may need to get a paper or something to understand, you know, what the transitional arrangements are with regards to discussions and planning and arrangements, because the model going forward is a totally different model to the current model. And I think I just wondered whether there's any paperwork that's going to be made available to make sure we have confidence to know that the patient voice is not lost during any transitional arrangements.
Thank you, Paul. I entirely agree. Continuity is absolutely at the top of the list, not only for the CHC movement as it transitions into the Citizens' Voice body for health and social care. Now that the board of the Citizens' Voice body is established with its chief exec, we are expecting more of the structure and the functionality documentation to come out shortly. We are waiting for the Welsh Government to go out to consultation on the code of practice on entry to premises, where, you know, largely we undertake our visits at the moment, but also the statutory guidance on making representations to the NHS and local authorities. But as an Aneurin Bevan footprint at the moment, we've been given assurances that the local footprint will be retained. Particularly for Aneurin Bevan, we will stay as we are and transition into the new body as is. And actually, I'm working on the premise that in health, it will be seamless, and relationships therefore then need to be built with social care providers and the local authorities in the similar thread that, you know, this CHC works with this health board. So I'm very much of the view that work as is under the current framework that we have. And I know that I'm making plans for 2023, 2024 with your exec team, as I do at the moment. So we are looking for continuity in our health because we already know what we're doing there and we do it extremely well, and try and replicate that into social care providers also. So I think this is more about relationship management and building at this time, because the CVB's functions will largely continue as they is. We'll still have a role in service change, we'll still have a role in scrutiny and making representations. It will be a duty for us to continue to engage at the point that people are receiving services, and our advocacy service will extend across social care also. So I'm very much looking forward to the documents that will set out how we do that in the future. But at the moment, I'm working on an as-is premise.
Very much.
Thank you, Jim. I think it's really important that the chair of the Citizens' Voice organisation communicates effectively and quickly with the health boards in particular to assure them of the arrangements and to assure us of the type of relationship we can expect and what difference, apart from social care, and local authorities, that this new body will make. Because, you know, we do have a good and challenging relationship with the CHC in the Gwent area, which I think we would not wish to lose. And we wish to be assured that we are going to get that similar patient's voice in our midst as a continuation. So we will write and express our wish. Okay.
Thank you.
Thank you. And Gemma, as always, thank you very much for the report. I think it's really a way of us understanding what people are encountering within our system. So and it's not, this isn't actually a question for you, but it's something that's arisen out of your report around the signage at YYF. And I've had a few people recently speak to me about signage actually at different sites. So the Grange, the Gwent, Neville Hall, and now YYF. So signage is something we probably need to have a really good look at. I think the feedback that I've received is not so much about signage of where do you find individual wards if you're going for an outpatient's appointment, but more what do you do when you're in a bit of a panic because you've got a sick child or you've fallen over or whatever it happens to be, and you want to try and find somewhere urgently. And I think that leads to frustration, which is also difficult for our staff then, because you've got a frustrated patient who hasn't been able to find where they're supposed to be going. And I think you know, but once people get into the department, of course, they're faced with a much calmer environment. They feel looked after, feel really well cared for. But it's about how do they find their way in. And an example that was given to me was two examples. One of which was somebody who went into the building, was told they needed to go back outside and find a window outside and couldn't. And someone else who was out in the car park late at night in the rain, you know, struggling with somebody who was really quite ill. So I think there's something that we can do to have a really good look at the simplicity of signage for those areas where people want to access our services in a hurry. Yep.
Can you take that forward?
Yeah, it was only just to thank you, Jenna, for the reports. They are really helpful. I just wanted to pick up on the ambulance rates, because we've talked a lot about people who sit in the waiting room, and like you know, we're extremely concerned about people waiting for an ambulance in the community. You know, some of the patient stories we have are quite just completely unacceptable. So, you know, there's a huge amount, it's part of the moving to plan, as you said, the whole system, but we have got a couple of initiatives that are part of the plan that are happening in December, particularly reconfiguring the first floor. We've got advanced paramedic practitioner going into the flow centre to work alongside colleagues in January, where whilst believing will reduce conveyancing. We've also got additional free TV for GPs linking into the flow centre. So there's a couple of things happening in the next month or so that we are hoping will have an impact, as well as hopefully expanding our same-day emergency care unit. And we also folks, so there's ambulance summit on Monday, which was with the Minister and Welsh Government and all health boards, and someone from Warsaw. Was actually really interesting in terms of Cardiff have made some really, you know, stark improvements in the last 2 months that we've been speaking to them and learning from what's different. We've also been to North Bristol in terms of some of the flow management, and Warsaw that was on the call have also done some because we are trying to look and learn from elsewhere as well. And we are introducing kind of a heightened escalation process. We've now got weekly focus and executive team to make sure all immediate red release requests are accepted, and if not, why not? And also trying to get a 4-hour red line on a 4-hour wait outside, which is still not what we're striving for, but it would be, you know, we're still having too many 4-hour waits. You know, this is monitored across Wales. So I just wanted to add on, you know, our shared concern about ambulance waits and some of the work we're doing to try to impact and how you then spread that risk throughout the system, because it can't all be held at the front door. So that's, you know, it's a difficult balance in terms of where you spread, how you move risk and spread risk, but it's something we are prioritising as a team. So I thought I'd just share some.
Perhaps we can have a report on that at our next meeting formally.
Yes, thank you.
And any further questions, Gemma? Any further comments, Gemma?
No, thank you, Chair. Thank you, everyone.
Thank you, and thank you very much. Can we move on to 2.2, the patient story and virtual ward? And I'd like to welcome Will Beer, who's the interim divisional director of primary community care. And on Teams, Dr. Sue Thomas, the primary care cluster NCN lead for Newport West, Kate Morgan, the district nurse team's leader, and Dr. Jane Norton, the GP, who are joining us today. Thank you. Well,
Chair, Sue is going to take us through the presentation on the screen and talk to you a bit about the virtual ward model that's been developed in the Newport West NCN. And it's very much been a collaborative effort between the GP practices in that area with social services, district nursing team, frailty, and some of the third sector providers. So we thought it was a good example to share with the board today. So over to you, Sue, to run through the slides.
Thank you very much. Thank you, everybody, and thank you very much for inviting us to make this presentation. We're really pleased to share some of the work that's happening within the neighbourhood care networks. And I'm Sue Thomas. I'm the NCN lead for Newport West. I'm also an advanced nurse practitioner in general practice, hence my background here. And also I've got colleagues Kate Morgan, who I think you can already see online. She's the district nursing team lead from within the Newport West patch, and also Dr. Jamie Norton, who's a GP at St David's. If it's okay with you, I'll just run through a couple of slides as a sort of background and introduction to the work, and then we'll hear from Kate and Jamie as to the practitioners' sort of contribution and perspective on what's been happening. So, just to start off with this slide, just to orientate us all to what we're trying to achieve. Really, it's to do with the NCN looking at helping to support the health and well-being of the people within our patch, and it's a large patch. We've got sort of 80 odd thousand population within the Newport West area, spread across 8 general practices, a couple of which are very large, and you'll hear from Jamie about one of those, and then others which go down to a size of about 5,000. So each of the practices has got involved in this scheme. So we start to look at what health actually means to us as an NCN, and we draw back on the WHO's definition of all those years ago. So we're talking about health being a state of complete physical, mental and social well-being. It's not just to do with absence of disease or infirmity. And we also sort of subscribe to the notion of the biopsychosocial approach, which is all about considering those biological, psychological and social factors, but more than that, that it's their complex interrelationships with each other, and that's how we try to understand health, illness and healthcare delivery as partners of the NCN. So thank you. Next slide, please. So if we do consider that that's what we understand by health, and we'll also understand that it takes all of the partners within the NCN to be involved together in any of the work that we take forward. It's not just down to one section or one sector or one partnership group. We do subscribe to the idea that we all need each other in order to help and support people. So the multidisciplinary team virtual ward is all about structure within the place. So that's the place being Newport West. There's all the partners who come together to support people within that place-based care sort of idea. So what we're talking about is a structured, either face-to-face or virtual MDT conversation. So face-to-face would be all in one room. Then of course COVID happened, and so pragmatism has taken us into a virtual sort of arena. Some of them now are returning to face-to-face or indeed remaining as a Teams facilitated conversation, which of course in many respects helps partners to actually get to those meetings because it just is easier within the diary. So it's a conversation between a range of multidisciplinary and multi-sector professionals where people with a variety of complex and interrelated issues are discussed and care planning takes place. So this is probably somebody who one or the other partner has felt that their resources, their own skill set has sort of been exhausted, and they really would normally perhaps refer on to somebody else, but rather than make that referral and decide who could be the next person to support the individual, actually sitting around a table with a discussion, it enables all of those partners to be able to say, oh well, actually I think I can help here. Oh yes, I also know this person, let me go and do this. And it just helps that conversation to effect that sort of more immediate sort of referral, if you like. It addresses the risk of deterioration for people. That's what we're aiming to do, is to improve their health and well-being status, but also to prevent identifiable future problems from occurring. So in bringing people together in one place, the virtual ward aims to increase the level of knowledge about potential resources and support or care options, because we don't all know everything about everything and what's available within an area. It's to help facilitate people receiving the support for their health, social or other needs from the right person or partner or agency at the right time, with the aim to improve outcomes for that person, including that they stay healthy for longer, and remembering that the definition of health is very broad. It aims to avoid delay in referrals and in doing that to reduce avoidable hospital admissions where time elapses and deterioration continues. But it's also aiming to improve necessary, so where there is the need for somebody to have a hospital intervention that would be short term, to help to improve that in order to maintain people's health independence. So that whole idea of if a hospital admission lasts too long, the person's independence is going to be affected, and also to keep in place the continuity of any support that's already there for that individual. Thank you. Very clunky sort of homemade diagram, as you can see. This just to sort of show you that the ward, the virtual ward, is all about individuals, and then a myriad sort of scheme there of partners who might well be involved. DN, GP, people from the community resource team, OT. We've got occupational therapy, physio, community mental health, the older person's pathway, advanced practitioners, pharmacists, social services. It's whoever really is around and available and relevant to support that person. Thank you. So where we've got to and what the NCN has supported, it started off by using NCN monies to backfill one GP or another practice employed professionals' time to the tune of one session per practice every 2 weeks, to enable that person to lead and to be involved in any related activity for those scheduled virtual ward meetings. That's been key really to the success and the growth here, because of course general practice does hold the general medical record for individuals, and it means then that record can be explored. It means that it can be updated. It means that information can be retrieved. So looking for safe sort of conversations to take place. If we have somebody in the room who's got access to WCCIS, then that also does enhance the conversation, but that's not necessarily possible. So we've also appointed an occupational therapist who is practice-based, with the idea that they undertake first point of contact consultations with individuals who might want to be seen for mental health or psychological sort of well-being needs that would normally present through the front door of general practice. We've appointed a pharmacy tech who has focused on issues relating to medications for people that are discussions that arise at the virtual wards. We've latterly now appointed a virtual ward coordinator who's helping just to make the system sort of work, so that, for example, all the virtual wards within the 8 practices aren't scheduled on the same day, so that other partners, can actually get to attend the thing that those sort of systems items helped. We started off by purchasing and providing items to facilitate the virtual ward. So, the IT, things like projector screens and adequate seating for people to meet together. Also, one of the practice managers has developed, and then we've distributed templates that can be used both in the EMIS and Vision electronic patient record systems within the general practices, and we've got half and half practices using EMIS and Vision to help to guide the virtual wards. So, for example, somebody being in to discuss that person's record just pulled up, they can immediately be coded as being discussed via a virtual ward, and then any discussions can be captured, which also enables that embedded coding to be retrieved at a later date for us to be able to monitor some of the activities. We've also funded post-discharge phone calls for adult patients, within each practice who've recently returned home after a hospital stay, to help to enable continuity of care and reduce the risk of avoidable readmission, with the aim to pick up concerns at the earliest opportunity if there are any that otherwise might escalate. We've got a diverse forum, diverse communities forum, and also, we're really making great strides in close working with the integrated wellbeing network within Newport West. So we're doing a lot about enhancing partnership and I have to say that relationships are just improving because of these coming together of various partners. Thank you.
Thank you, Sue.
But just very quickly to share some of the feedback. You can probably read for yourself. I expect you've got a screen there. You can see that these are the professional comments and show how the entities would work, but now can't see how we could work without them. GP can now practice in a completely different, more holistic way. District nurse gets them away from the medical model. Notably in the middle, I probably would otherwise have admitted her for one of the GPs. Pharmacist now understands how the whole system works, so it's stopping people just working within their own sort of area, not so afraid of opening a can of worms, and sitting together with health professionals is really helpful. That's the older person's pathway facilitator, who I have to say has become seen as core to the virtual ward conversations, and also the idea of identifying problems earlier so they don't fall apart. Just to give you an idea of how it's working for the partners. And I'm just going to, we're going to move on to the next slide, which is going to just show you a couple of case studies, and Kate is going to do that. And then at the end of that, there'll be just a summary slide. And then I know Jamie will just give you his perspective. So thank you, Kate.
Hiya, I'll just give you a brief overview really of just making it a bit more real, and just to discuss probably some success stories really of the virtual ward rounds. So this first one is a lady who lived alone. She lived in sheltered accommodation. Her daughter wasn't close by, she lived away. And this lady desperately wanted to get closer to her daughter. She was very low in mood due to her social situation, and she wasn't eating, she wasn't generally looking after herself, and she had a significant weight loss. So what we found was, before the virtual ward, the first protocol was always the GP, and it came to light from just working in the virtual ward rounds with the MDT that it's often not the GP that the patient actually needs. So when you sit down and discuss patients in the virtual ward, it becomes evident that there's a range of people that can help people that doesn't require a GP intervention. So just from discussing this patient known as Lizzie, she had a medication reviewed by the pharmacist. They improved her medication regime. She was referred to the older person's assessment, which led to just making contact with her, got some aids in and adaptations in her flat. She had a Zimmer frame, she was able to mobilise. So all just these little improvements within the MDT greatly improved her mental health. And eventually we were able to make contact with the MDT in England, and we managed to get her moved to her daughter. So it was just a bit of a success story really, that just from speaking to people within the virtual ward rounds, that she could be helped quickly, because you're in contact with all these different professionals, not just health but social care as well, and the voluntary sector. And this lady's just a general condition, both health and mental health, had improved just from being discussed at the virtual ward round. Is that one? Another one, just quickly, this patient we called John. He was a 69-year-old gentleman who lived alone again in sheltered accommodation. He again had concerns about his weight loss and lack of appetite. Mobility as limited due to cellulitis of his legs. Very poor social situation and very lonely. He lacked any ability to provide personal hygiene, and he also needed help with his household cleanliness and maintenance. So a mental capacity advocate assessment was confirmed because he did have learning disabilities which had previously not been recognised. So he was assessed to his capacity to make decisions about his own health. We managed to get involved with OTs and social services, again through third sector parties as well, just to improve his general well-being. District nurses were involved to monitor his cellulitis, get him into the correct leg compression and all different therapies to then improve his mobility. So just from, again, discussing him within the virtual ward round, his mood was improved, his social circumstances had improved. He was even referred to befriending. So we had some support socially, not just from a health perspective. And he's now out, he's got motivation, and he's out walking his dog, which was, it sounds little, but it meant a lot to him to be able to get back on his feet again. Right.
So before I just asked Jamie to finish up with what we're doing is continuing to develop this model. The whole NCN has agreed it being the means of achieving place-based care across the patch. So that's all of the agencies. You know, we work very closely with our local authority partners, new members of staff there. So, you know, really productive shared conversations. We are currently seeking a community matron, clinical lead case manager role, which is currently we have a job going through job matching. What we want to be able to do is develop additional ways of proactively identifying and focusing on people who are the most vulnerable. We want to sort of improve our place-based care sort of coordination or case management to people who've got complex longer term needs. We want to be able to better prevent avoidable hospital admissions and to enable continuity of support needs. So that's a role that we're really exploring and trying to, you know, continue to close any gaps between our partner providers. And of course, it's all about trying to seek additional sources of funding. So we're really sort of hoping that the new structure for the, you know, you'll have heard about the advanced cluster development or the NCN development work, whether that will give us opportunities. But the bottom 3 bullet points does point to, you know, that the skills that we do need to be able to make better progress as NCN. We do need skills in sourcing fund streams and in being adept at business case development that currently we still, you know, are learning. We definitely need to close the gap in developing an evaluation plan. What we want really is to use a variety of methodologies so that we do have a comprehensive understanding and that we can learn, adapt and grow. And so we've made some steps with that, but we've got a way to go with it. So, you know, we're still on our journey, but we do feel that progress has been made. That's it from me. I'll hand over to Jamie just as one of the GPs who's involved, just so that you can hear from him. Thank you, Jamie.
Thanks, Sue. So I'm based at St. David's Clinic in Newport, and we've evolved over the last 5 years from probably 5 years ago, small practice with a core team of GPs, about 12,000 patients now, to a large multidisciplinary team, over 20,000 patients, really diverse team over 3 GP sites. We've got GPs, paramedics, prescribing pharmacists, physician associates, physiotherapists. So we really embrace, you know, the multidisciplinary model, and obviously I'm here talking because it's been a very positive experience for us. Our virtual MDT is now led by one of our paramedics, who we've a team of two paramedics who do a lot of our home visits. What we found, you know, there's a number of points really just to highlight. The MDT with the district nurses and the older adult team, social services, what we found is that the communication, two-way communication, is really improved. You know, we're on first name basis with the district nurses. They know they can pick up the phone. They can, they know, oh, call Jamie about palliative patients, or, talk to Tristan, who's our paramedic, or how, they know exactly who the point of contact is. I think we've removed a lot of the barriers, by developing relationships. And I know that's hard to measure, but that's really powerful. We're working really closely across the community. So the meeting, also it provides a sounding board. It's a method of sharing risk. And I know, Kate has highlighted there in one of the case reports, the GP isn't necessarily the right person to help with some of these patients. And the meeting has been really useful just to signpost patients on to the correct professional. Also, all practices are struggling with demand at the moment, and sometimes the most vulnerable patients can find it difficult to contact their GP or get access to the GP, rightly or wrongly. And the district nurses and the specialist palliative nurses, they can contact us, highlight patients within the meeting and say, look at this patient, you need to see this patient, or action is needed here. And that obviously can prevent unnecessary admissions. The other thing is, anecdotally, although we haven't measured this, but our feeling is that the meeting has we have reduced those kind of frequent callers, those vulnerable patients, frail patients who are calling us several times, every week or even more. What we found is that they've been I suppose referred or signposted on to the appropriate services. So, befriending services, support through the tertiary sector, or on to social services. So that's been great. We do feel as well, again, anecdotally, we haven't measured this, but we feel there has been a reduction in social admissions. Interventions have been put in place before a crisis occurs. So overall, I think we've really had a really positive experience. I think I just looking at your last slide there, Sue, the GP comment, I'm not afraid to open a can of worms. I think that's, being perfectly honest. Yeah, GP on a busy on call, a call comes through 5 o'clock, you've got a list of 10 patients or whatever to be dealt with, you're acutely unwell, and you've got a case of perhaps a social issue that might result in a admission. To be being honest, sometimes those aren't prioritized by a GP. You're going to prioritize a febrile child, possibly. I'm just, as that GP has said, you don't want to open a can of worms, because these are complex cases that are very difficult to manage on a busy on call in an afternoon. And the advantage we now have is that we can say, okay, we can deal with that on Thursday in our virtual MDT. We can get the nurses and or perhaps a palliative team involved in discussions, social services. And again, being perfectly honest, nurses, paramedics, allied health professionals are often better at managing these patients. They're better at picking up the phone and coordinating care. We as GPs, our primary role is diagnosis, management plans, medical management plans, and it has certainly helped us, helped our workload, so we can focus on where we're best needed, and these types of cases are managed by the appropriate professionals. So yeah, it's been very positive from our point of view. Thanks.
Thank you, and thank you, the three of you very much indeed for providing us with this, a really very helpful insight into the development and the improvement which you have managed to put in place in terms of patient care and access. Has anybody got anything to say, Chris? And then James?
Just a couple of things really. I think for me, I think this is just a really good example for us in terms of demonstrating the difference, how collaboration within our neighbourhood care networks can make for our population. For me, this is absolutely about providing place-based care and support as close to an individual's home as possible. I think it not only provides the benefits that colleagues have articulated in terms of benefits for citizens, but also I think Jamie and Sue have benefits for those staff who are working in primary care and community services at this point in time, who are particularly faced with real challenges around sustainability and well-being of staff who work in primary services. I just want to say I'm really mindful and thank you to all three of you. I know you talked about it basically this morning, so thank you so much for presenting today. And I think the other bit just for the chair is around evaluation. I continue to take the point that colleagues have raised in terms of we need to be doing more evaluation of these things. The additional infrastructure, the amount of the NCN office, the room there to do more evaluation, and thinking about scale and other areas. Yeah, so their evaluation is clearly key, but what we're dealing with are highly complex cases, and I suspect the benefits may get focused on numbers, and actually the qualitative patient descriptions given of how the services responded to people's needs, I actually think is actually a rich feedback, because in my own clinical practice, I've met people, one of those people who have described and fully understand just how hard it would have been to manage them in the community, but also how hard it would be for them harder to manage them, how they ended up in hospital. So there were so many innovative things that you've spoken about there. It's just really exciting. So I hope you don't mind. I've already emailed a member of our redesign service for the people team and asked them to reach out to you just to understand what you think the key components of the services we're offering are, so that we can make sure that we incorporate that into the wider planning across the health board. One thing, a more natural thing from what you just presented is, James, I think you described you did work in a small practice, but you now work in a much bigger multidisciplinary team. And we've had a lot of discussions in the health board recently about resilience of GP services, given the sort of staffing and recruitment challenges that are being seen throughout the country. And for me, what you've just described sounds like a really enjoyable place to work, because you're using your key skills, and because you're now working in a large group of people, there's a sufficient critical mass that you've been able to employ and retain people with complementary skills, that even though patients possibly have to travel a little bit further to get help, the help that's available is far more rich because you've concentrated into one area. I just would be very interested in your reflections on that, and reflections of anyone else on the call.
Yeah, we still have three sites, so patients don't actually have to travel far. But in terms of resilience, I think yes, it certainly helped us. So when for example, this week, we've had a couple of clinicians call in sick, but we have the as you've said, the critical mass to adjust, change rotas, to manage, and yeah, like we as I said, we've got two paramedics. One of our paramedics is now a partner in our practice, which again is, I think that's quite unusual, but I think that's the way things are going. We've recently employed a physician associate, who she is absolutely fantastic. We're we've two pharmacists who are training to be, one is just passed their independent prescribing course, and the other pharmacist is keen to prescribe as well. Recently employed a physiotherapist. We did have a CPN based in the practice, but they moved on. So we're really, I think the way things are going for us actually is that the GP is almost becoming like a consultant in the practice, where you you know, the allied team are, will see patients, and then we any queries they have, questions in terms of management plans, they're coming to us. So our days are becoming, we're actually for the on-call GP, we're actually becoming more, as I say, more like consulting to the wider team and answering queries and backing up management plans and discussing risk, rather than actually, we're still seeing patients, but that's becoming more of more of our role now as time goes on. And yeah, so far so good. I mean, it is, I'm not going to lie, recruitment is still a challenge, but we seem to be we seem to be doing okay at the moment, better than most, that's for sure.
Congratulations to everybody on innovating despite the fact we've gone through a really difficult time. It's really impressive. Thank you very much. Rob, Jenny and Paul. Actually, thanks everyone. Really quite impressive presentation. Feels like you're aiming for the future state of primary care and you're nearly there, so really, really good. What struck me is on one of the slides around the support for, I describe it as sort of business management support. I'm sure I'll liaise with Chris, and we can help out on that with some of our teams here. So that's certainly something we can do in the short term and the long term to help this out. Good. Is that just one? Jenny? So just very briefly, so I'm Jenny Winston, I'm the new Executive Director of Nursing. I'm actually a district nurse in health visitor by background, so much of this work is, and we remember the community matron role was rolled out in England some years ago, and there's a really valuable role around prevention, very complex older people, and actually it's been really effective in that predictive analysis around preventing admissions and ensuring that people remain well at home. So I'm really pleased to see the MDT approach. I would say GPs are pivotal, but as you say, James, your role perhaps needs to be slightly different for the future. I'm really pleased that we are able to see that MDT approach developing. I'm really happy to work with practice around the community matron role. It's something I've already discussed with Chris, because I think there is some learning that we could bring in, but also really to think about, these are the very patients that will impact on WASP. There'll be the patients who sit for 20 hours outside of ED. There'll be the patients that sit on awards for very long periods of time. And if we can do something very different, it's rewarding for the professionals, it's rewarding for the family, and it's the best thing that we can offer that patient. So very happy to support. Thank you, Jen.
Just to say congratulations on the work. I think what it does evidence is the fact that this is a wraparound provision for individuals, rather than going, I think it was said in the presentation, people going into the GP surgery and just in a medical conversation. The only thing and I think there's a huge sort of making a difference involved there. I would suggest to you probably should map out possible inputs that's available from the voluntary and third sectors, because this is an incredible enrichment amongst those sectors and individuals can be there to support. And I do think the community mental health practitioner is probably something that is also pivotal as well, to be part of MDT, because then you really have got the complete holistic range of provision that be available there to signpost and support. But I think it's a great step forward. It's really creative and innovative, and to wish you well
future. Thank you. Phil, Pete and Sarah. Yeah, like everybody else said, just to congratulate the team. Really. It's a tremendous thing to see this, and of course, this is really the new model, isn't it? This is place-based working, and this is what we need to roll out and build on as being the way that we actually run our services. If I'm being critical, perhaps I think it's a bit critical. Perhaps I'd say that a concern might be for me that it still feels a little bit light in terms of social care actually being in the room. There were several comments about we've managed to get social care to do this, or we referred into social care to do that. And I just wonder whether to the development and growing this model that we need to think about how do we actually ensure the social care is absolutely in the room with the other professionals and not seen perhaps as an agency that we refer on to, even though we might be on first name terms with them when we do the referral. I think it's just something to think about. How do we ensure that we're actually being totally multidisciplinary right within the room? Because it's a subtle difference, but it makes a hell of a difference when you actually get the profession in the room as opposed to be referring on to them. And I just think if we really develop this as a place-based model, that's something that we perhaps need to think about in terms of how we go forward with something that is clearly working and making a difference. And once we get social care in the room, the next development for me, which would be a real game changer, is to get the care providers in the room as well. So what we ought to have as part of the MDT is the local manager, for example, of the domiciliary care providers, or maybe the local manager of the nursing home. I mean, that would really make the difference to a proper place-based model. And probably a year or so down the line, if we could achieve that, for example, if you need to refer into social care, you wouldn't refer into the social care council offices now, you refer into the MDT.
Yeah.
So you take away a tier from local government, which they wouldn't have to fund. They can then perhaps move some of that resource into funding a new model, which is actually the MDT and the NCN, really, which is the place-based model. But I think because we've got such innovative people who are prepared to do this is such a good start. That is something that we really need now to build on, and we push it as much as we can. And I wonder whether this presentation would go very well at somewhere like the Regional Partnership Board, for example. But we ought to be talking about these issues because that's where some of the decision making could take place about how we move from the current model, which is outside this kind of idea, to make sure that we are working in a whole system way. But generally, it's really good to be hearing this. I don't mean to sound critical, I mean to sound thinking about where do we need to go next, but it's a really good work. Did you want to respond, Sue?
Well, thank you. Yes, and thanks, Phil, for those comments. And you're absolutely spot on. And it is definitely what we're aiming to achieve. And you know, discussions with the director of adult services and the director of social services generally is the two new positions, and they're very much behind this. And I think as far as they're able to, then they're supporting your proposal. But I think that anything that helps to put this sort of way of working into the sort of strategic direction and you know work program of those agencies would be really very helpfully facilitated. You know, if you think that RPB would be a place to have that discussion, I think that would be really useful. It would also help not only to have the right people in the room, and they are as much as possible, but it's not always possible. But of course, it does help because of the different systems that are used. You know, with the level of information and improving just the knowledge that and the safety when you're having a discussion about an individual. So absolutely, yes, please, and anything you can help to facilitate improvements there would be very welcome by us all.
We can take that forward, can't we, Phil, in the RPB? Tish?
Thank you. Again, congratulations. I'm really pleased to see the way that we're going. Interesting that I'm going to have to read it off here. The biopsychosocial approach was described back in 1977, and here we are thinking this is new and innovative. So you know, it's great that we're moving on with it. I was really pleased to hear that the third sector are included in the model. And my question was going to be around we understand that the challenges in respect of resources, but what are the challenges in terms of the system? And I think Bill described some of that. Very much what you've said, Bill, in respect of social care. I'd like to see that reflected in integrating the third sector in exactly the same way. So that the third sector element of delivery is seen as absolutely normal and part of the system, as opposed to a referral into the third sector. And there may be system changes that we need to accept and work on to make sure that that happens around resourcing, around how we work, how we communicate, how we record, information governance and so on.
Thank you, Jean.
Sarah, and then Pippa.
Thank you, Chair. I just wanted to come in on the point raised about skills and development for the future, and just to note that we have a programme of work moving across development needs across NCNs, and somebody who would be supporting that work on a training and services position from the new year. And of course, I would feed back the comments from the team who presented today, and to make sure that we build that into the programme.
Thank you, that's really helpful. Pippa?
Thank you. And again, like everybody else, really want to reflect the amount of work that's going on, and I think it's a really good lens into the future. When we think about sort of complex cases, I think very often we tend to think of older people, and yet we shouldn't forget that we are going to have some complex young people as well. And I wonder about in the future thinking about how we can link into education, for example, because that's going to be another supportive element in this. And it, just like social care and the third sector, there's lots of supportive elements to this. And I mean, you know, there will be some communities where religious leaders or community leaders are going to be key as well. And I think it's probably worth us at some point evaluating in a very sort of qualitative way. It has to be qualitative, doesn't it? Because we're not going to be able to say, oh, well, if we do this for this person, it's going to save X amount of pounds, because it's about patient quality and keeping people at home and how they manage and independence and all of those things that aren't very easy to just say, you know, what's the number that's attached to that? But I think it's almost like we need a kind of second tier to all of this for the future, where we're thinking about planning about what other people can we involve. And around the table already we've had, you know, third sector and social care and all sorts of suggestions. And I've come up with education and I've come up with community leaders. So there is something, isn't there, about how do we develop this in the future that in a way that is supportive, so that we don't just leave all of the burden of that development in, for example, St David's, where they already have said, you know, that they would like a bit more help with planning, for example. So so I wonder where we can get this support to really help out.
Thank you. Well, I think the answer is probably the RPB itself, because all of the people are there. And I think that if we could make a determined effort to raise this at the RPB as a work programme for this following year, given that we have success, that we wish to build on the success, then, you know, really drive through the RPB the progress of this throughout the whole of Gwent. I think that would probably be it. We'll put it on the next agenda. Yeah?
Yeah.
Okay, right.
Excellent.
Well, thank you. Oh, heck, hang on. So we have got to get on. So
Well, just very briefly, I'm sorry, I don't want to take any more time, but just to reassure that the comments that were just made are things that we are on to. Although Jamie did come from St David's, he's only one of 8 practices, and most of what we've reported is to do with the NCN more broadly. It was just, I asked for one person to come and just to give you a flavour from that perspective. So we're very much engaged with the Integrated Wellbeing Network, and we are very much looking to make sure that all of those relationships do exactly what you've described at our locality level, and any support more strategically would be very, very welcome.
Thank you, Sue. Final comments, Sarah, briefly.
It will be brief, Chair. It was just, we've mentioned qualitative evaluation of key plans and numbers, and just to say that you can do very robust qualitative evaluation if you follow some basic principles about study population sampling frame and methodology. So I think it's perhaps something that we're not used to doing so much of as looking at numbers, and perhaps that's the way forward here. And I'm looking at an expert on my left because Chris is very good at it. So I just think it's that using qualitative evaluation rather than quantitative. Yeah.
Yes, thank you. Okay, thank you very much indeed for that. And thank you so much for giving up your valuable time to come and describe what you have done and giving us a sort of way forward for the future, which is really, really helpful, and thank you. And good luck, and we'll raise it at the RPB. Items for decision, 3.1, the NCN development. Where are you going to sit, please?
Yeah.
Go there.
So, Chair, I think I'm going to introduce it.
Yes.
And then Bill's going to.
We have read the paper. Thank you.
Thank you, Chair. I think the presentation we've just had takes us very, very nicely into this paper. So the paper that colleagues have in front of them this morning is a recommendation in relation to the governance structure for the board to consider in relation to the further development of the neighbourhood. There's been a significant amount of work, I think it would be fair to say, in terms of developing the proposal that colleagues see in front of them this morning. And in order to shape the recommended governance structure, there's been a lot of engagement by a workshop with a range of individuals and agencies. There's been workshops with each of our 5 integrated service partnership boards. There's been detailed discussion with our Neighbourhood Care Network Programme Board. And I'm also very grateful for the support we've had from Rami, the Director of Governance, to help us think this through. Thank you, Rami. It's been a real challenge, actually, in terms of developing the proposed governance arrangements. And we wanted to try and take a very pragmatic approach that adds value to the existing partnership arrangements that we have in the region. But we're also mindful we've had to meet the ministerial requirements. And I think that's what we've been trying to do in terms of the recommendation paper that colleagues have in front of them this morning. I think it's been very open. Some colleagues have wondered whether if the structure that we're proposing has potentially increased bureaucracy. And I think we've acknowledged that we're going to need to continue to review and refine this and ensure it works for that as we move forward. My personal view is that by having the integrated service partnership boards taking on the functions of the pan-cluster planning groups, that's a real opportunity for us to reinvigorate the integrated service partnership boards and provide a much clearer role and focus for them moving forward. I think it's fair to say there are different stages in maturity at this point in time about integrate. I think it's also worth noting within the proposed structure, the only additional groups actually that we're introducing would be the NCN Programme Board and the Professional Collaboratives. And I think from my perspective, just hearing some of the conversations that are developing in relation to what the professional collaboratives will be able to provide for us, I'm really excited about those actually. So it's the opportunity to bring those professions together to think about how they work in a more collaborative way to support place-based working we've been talking about this morning. And just listening to some of the early ideas around the autonomy collaborative in terms of how those individuals can come together across a place and think about what they can do to support our citizens in a more collaborative way feels really promising to me. Before pausing for the discussion, I think it's probably important that we note that since we developed the paper, that a similar paper proposing the governance structure went to the RPB on the 15th of November, and it was supported at the RPB, but it was also noted at RPB the proposed governance structure was going through the appropriate governance bodies that each of the statutory bodies is coming to the board this morning. And the last thing I just want to do before opening it up for discussion is just to thank Will. I think Will has been amazing with this in terms of he worked tirelessly in terms of engaging all the range of stakeholders to get us to a place where we have a, I think.
Thank you very much, Chris. Do you want to add anything, Will?
Not really, Chair, just to say that I think, you know, although this may seem overly layered, the intention is to take effective models like the one we've seen earlier, make sure strategically we're heading in that direction and that our planning and resources are now aligned to deliver and scale up those models. So that's essentially what it's trying to do with this proposed structure.
And not create more bureaucracy.
Not create more bureaucracy, get really system level support for these kinds of models.
Well, thank you, and thanks ever so much for the work you've done on this and for the good quality updates that you've been providing to the board over the months as this concept has been rolled out. So any comments or questions, Bill?
Thanks, Chair. I mean, I think this is brilliant to see this coming board level. I mean, we've watched it grow, I think. Thanks to Will and colleagues, he's kept everybody in touch with where it's happening at every stage. I guess there's a bit of a birth of it today, if we agree. It's finally launching what we've talked about for some time. I guess for me, the real issue with it for me that will make it work are the what do we call them, ISPBs. I mean, they are the gatherings that really will be local, that should actually have the right kind of people to make the difference. Now, but in a structural sense, we've had them for probably 6 or 7 years. They've been there, they've been part of the original RPB structure. We've not had them in this particular guise because their importance in a way has been enhanced by the NCN developments. But I just wonder what grit are we going to have in the system to make sure that these bodies actually do the job that we'd expect them to do. Because it's not enough just to have them in a structure and say, well, this is what we expect to see. I think we need to have a bit more granularity in that and a bit more, dare I say, about performance management about, well, these are the people that should be around the table. This is how often you should meet. This should be what you should be looking at. I think it's going to need a bit more of a push to make sure that they actually are the game changers that they could be. They haven't been to date, although we have had them. So I think we're going to need something different now to actually make sure that they do make the difference.
Sorry, Jim, just on that, as you were talking earlier, Bill, about domiciliary care providers and care managers being involved in the MDT meetings. I mean, that would require us to move to a more place-based commissioning model for domiciliary care, which is, I would expect, sorts of things that would need to be discussed through those ISPBs. So that actually becomes a reality, because those are the people that can actually make those kind of changes. And then that would get us to think about, well, how do we then use our first contact team and social services and our community connectors? Now, should they be wrapped around the practices and be part of that MDT approach? And it's those sorts of changes I'm intending we're going to drive through the ISPBs, just as an example.
But we'll have to take the RPB with us so that they understand, because one of the issues was, is the RPB absolutely committed to place-based care, and are we all using the same definition? And I think we need to develop that over the next 3 to 4 months so we get clarity. Chris?
I think the only other thing, just to add on to that, Phil, I absolutely agree with you around how we really make the integrated service partnership work in the way that we need them to. And I think there is something about their reporting relationship to the RPB, how we can strengthen that.
Yeah, I mean, if they are working, of course, I mean, the RPB spend a lot of time deciding how to spend money. Well, actually, what we should be doing is sending the money down to the local boards to determine how they actually get looked at. I mean, it would reduce bureaucracy hugely at the top level, trying to decide what we do with resources. Yeah. You need to put money where the people are.
That'd be better ownership.
Absolutely, and more ownership and all the rest of it.
I think we're going to have to discuss this very carefully with the statutory bodies, because it's integral to the way in which we can deliver. And so I think that this paper going to the RPB is one thing. Now we need to make absolutely sure statutory bodies understand the role and responsibility.
Sorry, Joe, we did talk about, Chris and I talked about putting on some briefing sessions for elected cabinet members, particularly around place-based care, and we need this now reflected in the local authority's corporate plan. Yeah. Within the divisional. social services. So it becomes part of the lifeblood of the local authority as well as
Looking at the ministerial milestones on attachment 2, I just wondered whether there's sort of millstone in there rather than a milestone. Two issues that I think have been mentioned. One is to do with funding and budgets, which isn't covered, and the second thing is target setting and joint target setting. Maybe at maybe the regional partnership board level that needs to be discussed. The paper I endorse entirely, but target setting is important because people can be held to account for them. And currently, we have patients in our community or patients in our hospitals who should be in our community, and yet we're not sure what's happening with the funding. So if the patient, if there was funding for each patient, depending on where the patient was, could depend on where the funding went. So if there was a need for a hospitalisation, for example, then funding could go to the hospital. And there seems to be a big issue here that's being fudged in terms of target setting, who's been held to account and how they've been held to account. I think the health board has significant targets that it has to achieve. I'm not sure that within the local government situation and this particular issue, that there are any targets that have to be monitored and are being looked at. And equally, the issue of the funding is going to be crucial as well. So I just raised those as issues, probably for another conversation, not necessarily this board, because I think I applaud the document, but I think when I read the milestones, I thought, no mention of budgets, no mentions of targets, and no mention of who's been held to account. And I think, we are significantly held to account as a health board. And on this particular issue, I think we need to, as I think Phil put it very well, the granular of it is actually saying, right, this is your responsibility, these are the targets, and actually we can drill down into local communities in terms of numbers and say, well, you've got 50 in Caerphilly, can you please tell us how are those being sorted, managed, supported into care homes or whatever the need is? And I just think there's a bit more conversation perhaps for that to happen.
Thank you. Any further comments?
I know I'm not allowed to make a comment. Just relating to Jamie's point about the relationship with the service redesign programme for older people. So I think there is an important relationship with the MDTs. I think the MDT being able to access the rapid response services, being able to access clinics, being able to provide that emergency care at home to avoid a social admission, maybe overnight or over the weekend. So there will be that sort of horizontal integration as well. We're also working closely now with Andy Bagwell and Paul Mize and looking at making sure the NCNs and the MDT meetings understand, the routes through the flow centre into some of the emerging SDEC, but the other ambulatory care pathways as well. So in addition to the place-based model, we're also looking at the alignment with intermediate care and through into the acute care division as well. Just make those 2 points. So we have got those things.
Good, because I think it would be really helpful if you collectively, Chris, would actually describe what good will look like, so we know where we're aiming. And I think the other thing in managing the approval from the statutory bodies, I'm not quite so sure that there was such a huge endorsement at the Regional Partnership Board for the delegation of commissioning responsibilities. And I think that might have to be a second or third stage in this.
I think at the moment we sort of settled on we need to be lining commissioning to make sure we're not duplicating or we're addressing where there are gaps within the system, but not at that stage where we're looking at strong commissioning at the moment.
So a nice description of what good will look like would be really, really helpful. That's okay? Good. Okay. Thank you very much. Thanks ever so much for all your work, Will, and well done. You've made sense, but no bureaucracy. Yeah, absolutely. Thank you. Now then, where we go? Integrated winter resilience plan, then Chris.
Yeah, thank you, Anne. And first I say it's great. I think it's the third item in a row that's all about partnership working and increasingly our focus as a board and a group of executives is in that space, knowing that we can't respond to the challenges we've got without being in that partnership space. So what I was going to briefly introduce the paper, wasn't going to say too much because I know we've had a board briefing on going through the plan, and also this was endorsed at the Regional Partnership Board on the 16th of November as well. What this plan is attempting to do is set out a series of actions that we will need to take in order to respond to the challenges we're likely to face in this next period. And it describes some of those challenges in terms of the planning scenarios we've been asked to plan for, in terms of what we're expecting in terms of respiratory diseases, which is a challenge that in the most likely planning scenario, which has been set out for us by Welsh Government, sees about 14% of your beds occupied with people aged with respiratory disease. That's equivalent to sort of 270 beds across our health board area, or all of the beds in Neville Hall in effect in that scenario that we need to plan for, as well as understanding what a reasonable worst case scenario would look for. And importantly, recognising actually one of the biggest challenges faces us this winter and in this period that we're in at the moment is about staff and staffing and the challenge of staff absence. So the forecasts say that flu and respiratory diseases can add between 0.5% and 1.5% onto our sickness absence, which is actually quite significant, and that's across the sectors as well. That's not just us as a health board, but across social care as well, where we know those challenges are. And then there's everything else. So there's the industrial action, there's the challenges of weather. We're in an El Nino cycle this year, so we like to have a relatively cool and cold winter, potential for cold snaps, but then similar to last year, quite a stormy end of January into February. They're expecting high winds, heavy rain, and storms, similar pattern that we've had previously. We then factor in the cost of living challenges and people not heating their homes and the challenges that come with that, as well as then trying to protect and maintain our recovery activity as well. So there are many things that we're trying to reflect in this plan that we're trying to take action on. And I was watching the football last night, as I'm sure many others were, and reminded me, the lyric of David Ewan's song, Runny Amohid. Despite all this, we're still here. And despite all these challenges, we do have some actions, we do have some plans, and we do persevere, and we've still got some of those actions that we're doing. So within the plan, it sets out particularly what we're doing around health protection, so the work that's underway around the COVID and flu vaccine in particular, really important. The flu vaccine is a good match this year for the strain of flu that's circulating. So the best thing that people can do to protect themselves is get their flu jab. And it's good to say that's up next to the Director of Public Health. And recognising it's really important we're into the flu season proper now. We are seeing that impact into our system, and particularly in paediatrics as well. As well as it sets out the actions we want to do to keep people well at home. So the work we're doing around enhancing our community capacity, a lot of that being driven through the NCNs and the work we've heard described already in the meeting. Work that we're doing to enhance our front door capacity, and Nicola talked about some of this in her remarks around what we're doing around reconfiguring the first floor in the Grange and bringing more specialties to the front door as well. So physio at the front door and pharmacy at the front door as well. There's practical work we're doing around commissioning additional activity. So that's commissioning additional community activity, as well as some of our traditional work in expanding some of our areas and creating additional winter ward in Neville Hall that we're planning to come online in January. And then there's that work around how we support people to come home from hospital and also look after those medically fit patients within our system. So as we've heard described many times, the challenge of people in our system who should be at home, that we're working on the homeward bound units, so how we bring together people who are medically fit within our systems into areas where we can care for them in a different way. And the plans at the moment is the first area where that's going live is in the Royal Gwent, which is due to go live in a couple of weeks' time. So we'll start to see the impact of these schemes because we are into winter now. So the important question is, so what? There's a whole lot of actions in here. What is going to be their impact and what do we get from them? So you'll see within the plan there's a series of measures that we've set out, and we've worked to develop a shared dashboard of how we get the information of what's happening in our system as a shared set of indicators between ourselves, social care, local authority and other partners through the winter planning group as part of the Regional Partnership Board, and allow us to monitor and act and move when we see things changing in our system. The other piece of work we're working through at the moment is around reviewing our escalation processes, so that we're able to think about how we can respond in those particular challenging circumstances, and trying to expand those escalation discussions to involve our social care colleagues as well. So finally, thing to say is really it is a joint ownership plan. It's produced through the partnership board structures, and it's about developing that shared working in response to the challenges we're
Thank you very much, Chris. Any comments? Pippa?
I've just got one question really, and it's about the flu vaccine take-up with our staff and whether we've got any kind of update on that, because it's mentioned in the paper, obviously it's really important.
And that held to account by the minister for it. So that's how important you think it is.
Yeah, thank you. So the uptake is lower than in previous years, but that is the pattern across Wales. So we are working on a recovery plan to bring to the executive team next week, because we've already agreed it needs a real focus. But I think the important context is it's not local to us. It is actually a national picture. The uptake of the flu vaccine by staff across NHS Wales is lower than previously. And I was in a national meeting, and they were going to try and do some insight work to understand why that might be. But so we'll do what we can locally, but there's clearly something more fundamental going on that we need to understand.
And can I follow up on that? Is that true for the public as well? Do we know?
Uptake in the older 65s is extremely good. As you all have heard on the news, uptake in the under 5s is actually better than it has been in previous years, but it's never been terribly good. And I think a real focus on encouraging parents who may not have had their preschool children vaccinated previously to come forward for the vaccine, because that age group have not been exposed to a winter with flu circulating and actually other viruses circulating significantly. They haven't built any immunity, so they are particularly vulnerable to serious illness, which is what we are seeing. So I think that group is the real area of focus in the immediate term. And then we do need to make sure we are doing everything we can do, and we do have a plan around running catch-up clinics on sites for our staff. We know making it as easy as possible is part of the solution, but staff have to want to have it. I think something nationally going on about we want them to have it. But the key message is what Chris said, the match is really good. Would expect me to say I just thought it was fairly evident it was a good thing to have it, but clearly it's not for everybody.
Just following up from that, didn't we all used to have the flu jab? I think mine separately. Didn't we all used to have it here as a sort of, sure it was public health reason, but it was also public image for our staff that we, the board, have done it. Not sure it's sure it wasn't phrased like that.
I'm fairly confident my executive team colleagues have all had their photograph taken having their flu vaccine.
In a local immunisation centre, actually.
But I think we probably, because we haven't been meeting, you are absolutely right, Richard, we would, in the public board session, we would actually arrange it. Easily. Okay. Right. Yes. 2 seasons ago, that one, yeah. So indeed but that really is about making it easy for people and bringing it to people, and we know what works is people having to actively say no. And our really good peer immunisers, so it's drawn up, coming towards their colleague's arm, and the colleague has to say, no, I really don't want it, as opposed to staff having to go find it.
Thanks, Sarah. Any further comments, Bill?
Yeah, Chair, just to say, like several of the other documents we've seen this morning, we've watched this one grow over quite some time, haven't we? So we've seen a lot of it. I guess the more you read it, the more you kind of understand how much work has gone into trying to plan the week. Tremendous amount of work to get it at this point. Whether we've actually done enough, I guess time will tell. Whether there is enough extra capacity in the system, I guess we'll have to wait and see in some respects. But one of the areas that I'm not sure that we've absolutely bolted down is the whole system escalation. I mean, we talk a lot in the health service about escalation, don't we? But I guess we need to, and you mentioned this, Chris, and it's in the report about how we have some kind of an escalation system that actually involves community partners and all the rest of it, because it's one thing escalating things in a hospital setting, but what you do with that escalation when you've done it, if the rest of the system is still kind of logjam. And I'm not sure that we've ever gone into a winter with services running as hot as they are this year. We've also got the added problem of high numbers of delayed transfers. So I guess even though the system is running hot, there will be days when it's going to get a lot warmer. And I wonder on those days whether we need to be trying to hammer out a proper escalation system so that actually when we press the buttons, we know we're going to get a reaction. I mean, in a sense, what Will has talked about in terms of the NCN development, that's where the escalation should end in our new model, shouldn't it? It starts in the hospital, but actually it should end out at the NCN level because they are the people who can do something about a lot of the problem in the hospital. And I'm not sure they've actually bolted it down to that kind of level. So I would just urge that we really get on top of that, I'm sure we are, and try to make sure that actually that is very, very detailed. We know who to escalate to, and we know what they will do when they get the call.
Yeah, well, thanks, Phil. I completely agree with you. And when I made the session we had weeks ago, we were almost on the back of the winter plan. Is it going far enough? What are the things from particular situation of escalation we'd experienced the week before? Can we do differently? And we're kind of 5 themes within that, and one of them was about significant escalation. And I think, you know, whilst we've got comprehensive documents around major incident, business continuity, and lots of it, you know, there's 2 issues. One is the plan robust enough and is the system right? And secondly, are we enacting the plan when it happens? Because there's 2 issues that we need to address. So, you know, I want everything done by Christmas, as the executive keeps reminding me. But what, you know, we're not going to completely review the whole escalation. What Chris and I have had the discussion is let's put almost like a 2-page summary, easy brief, and what are the triggers with when we do our internal escalation first, where we bring partners into the room and try to get some of our partners that we're where we need a more broader system response to when, and also having the triggers, not just the 4-hour ambulance, but what are the delayed transfers and claim triggers, or at a local authority level, there's a trigger, and we do it earlier in the system rather than, you know, so with 50 patients waiting for a social care assessment in a particular, you know, is a trigger. Let's not, you know, so we start triggering a few things in the system, but also that broader, when do we bring directors of social services in onto the call? And we've got an exec team session on Monday with directors of social services. We've got an 1.5 to 2 hour slot together. And one of those would be, I think one of the items would be discussing in terms of how can we work together at times of escalation. So Chris is working on it in the next 2 weeks. So that as we go into Christmas period and then into January, we've got a bit of a clear, everybody's clear about what we're expecting to happen. And if people don't comply to escalation actions, is escalated at that point. Are we following up? So there's kind of 2 prongs on it that we do, which is a bit of a phase 1, how do we strengthen escalation in the winter? And then we do work in the background, which is making sure our broader plans are mature as we go forward, because we're not going to crack all of that in the next 3 weeks.
I mean, that's very encouraging to hear all of that. Clearly, things are moving on quite a pace. Do you still have an exact kind of discussion each day on the current state of the nation, or do you not have that?
As a health board, Leanne and team, they chair kind of twice a week. Senior leadership forum, senior leadership response group. There's calls that go on across the hospital sites every day, a couple of times a day. That happens now. And there's 11 o'clock national call. So there's a range of things, but you know, one of the things I asked Chris is, when do we as an executive team need to down tools and come together with our, you know, but what's happened before that, make sure that divisional teams have come together and the clinical teams have worked together so that everyone's clear at what point to put people in to meet in.
I just wondered that those twice weekly meetings that you scheduled, whether in your discussion with the social service directors you could convince them to have a nominated person to attend that, either a director or head of service, as a matter of course.
I don't think anyone will pick up that meeting.
Yeah, yes. It's called System Leadership Response Meeting, and we've worked really, really hard, Phil, and you've made it absolutely right. We can't pull sort of a lever in one place, and sort of because it is all interdependent, all parts of the system are linked. So we have a full range of stakeholders who asked to join us on a regular basis. We even have interest from police as well. I know. Lots of interest, as you can imagine, in terms of ambulance handling. The trickier bit has been sort of, we've had ad hoc attendance from our local authority partners, but it tends to be that Chris's team act as the conduit for local authority issues. And what that does, it gives us an opportunity to flag. We do a review of stats as well. There's a very simple sort of but comprehensive slide deck that gives us an indication of areas of what are the data signals telling us, where do we need to act, and there are things that we pick up. So YYF, for example, is shining bright at the moment because of the delays there. And I know Chris and his team are already on that. There's definitely more that we need to do in terms of the integration and sort of attendance at those meetings. We've got local authority representation on the Six Goals board as well, albeit we've struggled with other times when they've not been able to attend. I think covering that, and that's something that Chris and I are talking to them about as well. But completely agree, sort of that integration piece, having everyone sat around the table and understanding where we're at, very often driven by patient stories. We very often sort of try and target, this is the reason we're doing the improvement, this is why we need to change it, because I think it's quite compelling. But we've worked really hard to make that whole system, regardless of where the pressure is, because there are, as I said, interdependencies around how one part of the system is functioning and the impact it has somewhere else.
It's just that outside the health service, sometimes in social care, at difficult times, it can be seen as, well, the health service is jumping up and down about 20 ambulances like the Grange again. So what? If a social service director is on the phone to those people in the system, you get a different response. If the social service director is saying, look, there's a problem down there, I want you to sort that out, then it can be sorted out much quicker than it's being seen. Because a lot of people are fed up with fed up's the wrong way to say it really, but people are fed up outside the system with the health service constantly talking about all these issues. So you need somebody within the social care system to also be talking about them and saying, you've got to sort this out for us. It's just a different way of approaching it. That's why I think if they're absolutely around the table and feeling it, you get a different response and be referred into a problem.
But I think the point that you've made is absolutely right. But we've got to change the language around some of this.
Absolutely.
And some of the work that we've been doing around the homebound units, for example, and the engagement with the teams around this is not reduced length of stay. And what that does is years of deconditioning saved. Because actually, I think the system will engage with that, because that has a knock-on impact for local authorities. The dependency that they have when they go back out into their communities and homes is significantly enhanced. So I think the language that we use, the measures that we use, and particularly if we make them patient or citizen-centric, I think is where we'll get the engagement on this. Helen?
Thank you. Obviously, a very long list of actions, and I wondered what the mechanisms are for keeping track, and whether there's obviously a timeline associated with that.
Yes, that's through some of the operational arrangements we just talked about. There's groups that sit under the regional partnership in terms of monitoring. A lot of these actually are already happening now, so that are actions that we've already got inside. So we've got that monitoring approach through the RP.
What triggers the report to the board then?
So within that, in the report, you'll see there's measures that we put under each of the four themes. We've got a reporting arrangement we've just finalised this week, actually, with agreement from all the partners around the measures that will go into that. So we've got a dashboard of measures that can go back into reporting.
Sorry, right.
Questions.
Add to that, obviously, and also you talk about your data sets and having it ready before winter.
Yeah.
Just wonder when winter was going to start.
Winter is now.
Well, so your thermometer and your data sets, are they being collated? And
yeah, so we've agreed, we had finally approved the data set on Monday with all the partners, and we've got a dashboard. We worked with an external partner to enable to pool, because it's pulling from various statutory organisations, to be able to pull it together into a coherent dashboard information that we can look at to understand how we're operating as a system and where our things, the interventions we're making, have an impact. I'm happy to share the dashboard around that. I was hoping to have it ready to show today, maybe through the measures on Monday. So, but I'm happy to send them around as an action so people can see what we're monitoring, if that's helpful.
Yeah. Thank you. Anything further? I think we're all aware that we have never gone into a winter in such a difficult position. It's an absolute credit to the team and to the staff that we've maintained the situation to date. Let alone when greater pressures come up. Everybody's worked very hard to try and produce a plan that will alleviate the situation, but we already know we're heading towards the limits. And we will have to return to this, or we might have to take emergency action, really to ensure that we can keep people safe and respond appropriately to their needs. So I think we'll need to keep a very, very, very close watch on this and be prepared to discuss things that affect the emergency.
Can I just ask the impact of saying mild winter, cold winter? I mean, we're looking very kindly told us we're having a mild winter, which is great to know. But in terms of that, what's the impact it would have on the plan if things suddenly changed and all the horrible weather from Russia came to us or something?
Yeah, so we get a long range forecast from the Met Office, which is for the next 3 months. Their current forecast scenario is El Nino, so like to be cold and cold snaps, but could be similar to last. But that can change. Just takes isobars to a few levels to give you that really cold, and that's how Gareth's consequences come with that.
Yeah.
We'll speak to those more than me about the challenges of living in a house below 18 degrees.
But as well as the business continuity that goes with snow and flooding, when homes drop below 18 degrees, for each degree they drop, you see an increase in the number of people with respiratory illness and cardiovascular illness, heart attacks and strokes. So the cost of living crisis and people being worried about putting their heating on is likely to have impact on people who've got underlying health conditions. And so, which is why the message is about trying to keep your home between 18 and 21. But clearly, we know from the Office of National Statistics surveys that a high percentage of the population are already spending less on food and heat. So that is likely to have some impact in terms of increasing the number of unwell people.
Across the border in Gloucestershire, they've got this system of prescribing heating for the most vulnerable. I just wondered, is that in Wales linked in at all, or is it a separate conversation than England?
My understanding of that is that it was an initiative by the Clinical Commissioning Group who funded the pilot, and they've done the evaluation. So what we've seen in the news was the evaluation, but it is a locally funded pilot. It's not a national programme. We did have a conversation at the Public Service Board just airing the whether or not anything was doing anything. But I think that is NHS funding. The GPs are prescribing assistance with heating, and it's my understanding it's being funded by the Clinical Commissioning Group, which is NHS funding.
One thing we did identify through the collective sessions and Nicholas writes in those senior leadership forums is there's 47 different grants that are out there across Gwent that people can apply to for cost of living support, for heating support, for various schemes that are out there that local authority partners are aware of. So within the plan, we've got that action about how do we make it really easy for people to get hold of those. How do you have that 2-page about how you identify it? So that help exists out there. How do we get it to make it easy for people to find and how people find it early as well?
You want?
Usual financing question, I guess. In terms of our budget, what have we built it around? Is it the most likely or is the least of the worst case?
So that one in the plan help us get towards the most likely scenario. And the funding of the schemes is a combination of £4.2 million, which came from the RIF funding through the RPB, and the rest then is health funding.
There is potential just public health risks in the rest of budgets as well.
We were fortunate, I think, as an RPB to be able to release money. Don't know that everybody's opinion in that position. Nevertheless, it is an added strain on the budget, which we're very, very aware of. And they will be monitored too, because in this outcome framework that Chris will send us, it'll have all those indices we need to keep an eye on, including the resources, staff, money. Any further questions? Well, we'll see how we get on, and we're here to support you in any way we can. The research and development strategy then, a bit lighter.
Yeah. Thank you, Chair. It's an absolute pleasure to present this strategy, and it builds on the outstanding work that the development team and clinical colleagues did during the COVID pandemic, when, in part because we were an area in the UK where we had a large number of COVID patients early on, that they recruited to the really influential studies, the recovery study and others. And over the course of the sort of 18 months, our research team were part of describing the epidemiology, the recovery trial about what works and dexamethasone. Our respiratory doctors were part of the trial on the high pressure oxygen. And then we were a site for the AstraZeneca vaccine trial as well. So we, for the period of 2 years, we were generating the evidence and implementing the evidence as soon as it became available. And as the pandemic has progressed, we've seen the benefits of that evidence into practice. So at the start of the pandemic, the research team were operating out of a part of St. Woolas, which and they're now housed in a really beautiful modern clinical research unit in the Royal Gwent, and I would encourage any member of the board who's not been there yet to go and see it, because not only is it a great unit, but actually it's got fantastic art on the walls, and is a really good example of how the art strategy can help transform what is a relatively old space with some paint and some art, and the team are really buoyed up by that new facility. So that's the background to why it was the right time to bring a fresh 5-year strategy to the board, because it's been a while since we had one, and there are some external drivers here. One of them is a perfectly fair question from the Chief Medical Officer, which is, if health boards are university health boards, then research should be a core function. And that was linked to why we shouldn't receive grant funding to pay for our research director. It should be a core function. But I have to admit that I thought, well, actually, that's not an unreasonable position, because if you're a university health board, you really should have research as a core function. And that's why this strategy is about taking us in that direction. There are 3 strategic objectives. The first one is about, first part of it is about the funding and increasing the proportion of our research studies commercially funded. The very good news is that on the day of the formal opening of the unit by Nicola, a drug company came and looked at the unit and awarded us 2 trials without even going further. So I think that gives us confidence that that is a realistic opportunity. And then there's an action about embedding research, and there are some areas where we're already doing that. So like at the launch, I was talking to Dr. Thomas, who is a new consultant and the research lead, and he was describing how through the experience of the pandemic, research is now part of our normal ITU practice, and there are trials going on all the time, and that's what we want to achieve more widely. There is an expectation that an increased proportion of cancer patients will be recruited into trials, and so that culture of where the evidence needs to be developed, we have a 600,000 population, we need to be recruiting to trials. So that is that element of embedding it. And then there's an action around education, and you'll see in the strategy, there are a number of ways in which staff can develop their confidence and competence in research. So that's the first objective around a sustainable and supportive workforce. And then the next one is around investment in staff and infrastructure, and this is really about the rather than a cash contribution, a contribution in kind. So exactly as I've described in our ITU, and the strategy sets out a number of ways in which we can support our staff to undertake research. And there's a particularly important one there around the capacity of pharmacy, pathology and radiology to support research trials, because although we tend to get funding for the principal investigator, we tend to think about the doctors and the nurses. Actually, any drug trial has impact on those other disciplines as well. And then on the infrastructure, we've got our fantastic new unit, but our patients aren't all in the Royal Grange, so we do need satellite units in the Grange and Neville Hall, and therefore the alignment to the estate strategy is important. And then the final objective around a streamlined, efficient and innovative research programme. And this is about us being clear what we think our unique contribution to developing the evidence is based on the needs of our population. So the strategy includes things that are already strengths that we want to build on. And you'd expect me to have got a mention in there around health inequalities. We have an 18-year gap, that is a 20-year gap now in healthy life expectancy for women. We are a Marmot region. We have the link with the Institute of Public Health. We have the link with Public Health Wales. Yeah, we have a real opportunity contributing to that evidence base, particularly around the unique environment of the Wellbeing of Future Generations Act in Wales. So I think it's about being clear what we think we can be really good at rather than trying to do everything. And so it concludes with the ambition that the organisation evolves to become a fully integrated research organisation where research is part of normal clinical services and aligned to the needs of our population. So I'll stop there, Chair. That was just a brief overview, and I'm very happy to take any questions.
Thank you very much for that. That was really, really helpful paper, and we're very pleased that this is being pursued as bigger. Are there any questions? Helen.
I just want to comment really and say thank you to Sarah and the research team for preparing this report. It's very timely at the moment to raise the profile of research. As you say, a lot has been going on over the last 2 years, obviously around COVID, but to continue that momentum and with your new centre and things. I suppose the only risk is what plans you have, obviously the funding that's been withdrawn from Health and Care Research Wales, and obviously with financial constraints at the moment, is just to reinforce that research should be seen as a core activity because of benefits to patients and to staff, isn't it? So just wondered how we're going to deal with that situation and whether it's a large, what sort of amount of money is it that's been withdrawn and can that be accommodated?
So I thank you, Helen. And currently 80% of our funding comes from Health and Care Research Wales. And it tends to come with quite a lot of stipulation about exactly how it's going to be managed. So it sort of feels like grant funding with lots of rules attached. And what I'm trying to achieve with this strategy is it's the Health Board's research strategy, not Health and Care Research Wales strategy. And this is about us taking ownership of our own research programme. And as part of that, looking at the commercial trials, but also the non-commercial trials led by universities. So the AstraZeneca trial led by Oxford with a number of participating sites. So we are doing a number of those where it's led by a high-performing university research department, and we're a participating site recruiting participants. So and they bring income. So it is purposefully about making the board aware that there is a financial risk, but a clear, positive strategy around how we respond to that and stand on our own feet as a university health board.
You
Yeah, it was exactly around those lines, really, around what are we actually being asked for here? Because I see there's funding at the moment, but what of that is at risk? And, you know, what does success look like over the next few years? Is it to almost break even? Because, you know, we are all under pressures here in terms of costs, etc. And we've got to make certain decisions. And, you know, I get the reason we have research, and it does attract, and there is this benefit to us, but it's not benefit at any cost, almost. If you see what I mean, that there are some challenges, etc.
There isn't a cost. This isn't actually about, yeah, I'm very well trained. This is not impact on the financial bottom line. There is some threat to Health and Care Research Wales funding, and you know, the bottom line is we do less studies. We just have to cut back, but it's trying to avoid having to cut back by bringing in other funding streams. So I've mentioned the commercial trials, so it's explicitly about income generation is what I'm trying to say.
Yeah, but there's the other side of that. And if there's an opportunity for us to invest in this and get a better return out of it, there's almost an argument to say, well, we should be building this as part of the.
So it's the latter. I see this as exactly that. The strategy is setting out what I hope is a sort of organised, logical approach to doing exactly that. I think we need to be making the most of the investment in the new unit, which has largely come from the health board's capital investment, and bringing in the income and growing our research function through those other income sources. That's really the point of the strategy.
This was discussed at the All Wales Medical Directors meeting recently, and I would say that I think our local strategy is more coherent and realistic than the national strategy at the moment. I think there's still quite a lot of discussion going on about whether we want to develop our own USP for research in Wales, which is what I believe we should be doing, whether we should be trying to compete with cell biology that's been going on in Oxford, Cambridge for the last 40 years. And I think that's something that's there is stuff I think can do particularly well in Wales, and I think we are. The strategy provides a really good stepping stone for the future, and you know, I will be taking over from Sarah in January in R&D, and if R&D doesn't pay for itself, then we shouldn't be doing it. You know, there's a very clear link between research activity and everything.
To be honest with me, as an outsider, it doesn't seem to me as if we have enough centres of excellence in Wales. It always seems to be when you hear about exactly do not.
Right.
You know, if it's that investment, if we can get that investment, as you say, to get it paid for itself, and be almost a fund generator, no more than that. Yeah.
And what I called about being clear what our USP is actually that really, that we become a centre of excellence for certain kinds of research rather than trying to do a little bit of everything. And then that will attract people who are interested in research. The strategy includes joint appointments because particularly in our hard to recruit to specialties, there will be people who will be attracted by the fact that they can do some clinical sessions and some research sessions. And when looking at a team as a whole, a director as a whole, potential for certain parts of that, certain people in the directory with an interest to have time in there with to do research, and that is the department's contribution. So I think there's huge scope. It was really huge scope. We just need to be. I just think we need to be clear that we can stand on our own feet as a research organisation and have ambition.
Yeah, I was going to say, I mean, are we being ambitious, and what does success look like to us in 5 years?
So in financial terms, I would see that
that's the financial terms,
but partly in financial terms, if 80% of our funding is currently Health and Care Research Wales, that's the portion we would have grown, portion that's coming from other sources, so that as part of our growing our own unique portfolio.
Yes.
One of the other things is, look at the things from today, the MDT stuff, there's a lot of things we can showcase as well in terms of research that we're undertaking. And I think it's when we sit on the ACC panels, research is an area which I would agree entirely. I think it's one of these, it's been, in some respects, a sort of Cinderella type area where funding, I think, needs to be get into. Let's look at this with a far more sort of longer term view rather than a short term, and think, okay, what we need to develop. What I think was sad was we were offered some money, and then it was taken away, I think, wasn't it? Where we're going to have this new centre of excellence for something, and then we didn't get the money for it, or was that something else?
Centre of Wellbeing Excellence.
Yeah, I mean, the whole thing together, you know, I mean, I just think that what we don't want to do is to wait every year for a grant to come in and think, what are we going to do with the money? It's about thinking, okay, what can we invest in, or what private sector within Gwent is available to support really good work and stuff.
Absolutely, and it's putting the background, the wider links to improvement and innovation, and that part of the Health Laws IMTP. So, and that's evolving, and when we think about things potentially like the Medipark, and how do we do exactly that? And if one of our clinicians has a really good idea of new this technology, how do we do the research properly? Because there's a risk that things get called innovation and they don't go through proper trials. So that's, but once you've done that, how do you then get it into production without it having to go somewhere else? I think the scope's huge. We have a 600,000 population and a large workforce and a lot of enthusiasm. I just think we need to be clear it's about us having our own strategy rather than what Health and Care Research Wales tell us we can do for the grant that we receive.
Yeah, great.
And that's that's an important funder, but we need to move from it being our primary and virtually only funder.
It's important as well, isn't it? I think because, you know, ultimately the research that our consultants lead on improves the skills of our consultants as well. And if we invest in them, they will more likely want to stay with us. Then we will get better patient care at the end of it. So there are all sorts of things, and it's really great, I think, to see some quite spirited discussion about research, which people very often think is a bit of a dry subject. I wanted to say one thing, which you mentioned right at the very beginning about the artwork that is in the department. I think it really shows how the art strategy that we have gives a really good working environment, updates an old building. But I think the thing that I found when I visited was it really had energised the staff. They're very proud of the artwork, very proud of the space, and that made them want to work there as well, which again is another really good thing in terms of our workforce. So we have a report here to approve. I've taken over chairing from Anne, as she's got a minister's meeting, I believe, meeting at the moment. And so I just want to know really, is there anything else that anybody wants to say on this? Nick?
Yeah, it's just to sum up really. I think all the points are really valid. We've now got a fantastic facility that is nothing like we've had before. It was the only natal ward in the world Gwent, and it's unrecognisable. And as you said, it's made the best to show what we can do with old buildings. We've now got a strategy which sets out what our ambition is. And I just think does give us the foundation to do lots of what the conversation was just talking about. And with our university status that we're trying to do on innovation improvement does put us, and the strategy sets out when we head in with a facility that's now given us the potential to do so much more. So I just thought as a sum up, it's a really positive step in the direction with a lot more ambition than we can do going forward.
Thanks very much for that. Is there anything else? Are we all happy to approve the report?
Yeah.
I'm certain. I think you're getting a lot of warm feeling towards it anyway, and I do think it's really good to see. So the next item on the agenda is the anti-racist strategy, and I thought this was a really great piece of work. Sarah, I think you're going to lead. And just to begin with, I would say that we should put on a vote of thanks to Kerry for all the work that she's done. put that at the front of the report, but I'm sure you're going to say the same thing.
Absolutely, and thank you. And Kerry was due to join us today, but hasn't been able to join us. We've run slightly over time, but she was absolutely integral in pulling the work together and working very closely with colleagues in Welsh Government and other sectors as we progress. So if you may allow me just to take us through a short, very short presentation in terms of the key pointers which are outlined in the paper and the full detail of the action plan which you have contained within the board papers. So as we're aware, the Welsh Government through 2020 and 2021 consulted and collaborated on a draft anti-racist action following their commitment to an anti-racist Wales by 2030. They launched their action plan, which the detail of which is within the papers, on the 7th of June 2022. And the aim is to really make a real and measurable difference to our current and future generations of ethnic minority people. And the plan is aimed at being delivered through collaborative working through government, public, third sector and private bodies across Wales. There are 5 key priority areas for health, which are outlined in this slide, with a view to deliver through the values as shown in the diagram illustrated there. The key priority actions are contained within this, and you'll see within there timescales and expected outputs and measures as well. To respond to these requirements and our 5 priority actions, we've developed an anti-racist action plan draft for the health force, and we've been consulting on this through December to February of next year. Just wanted to highlight some of the key action and progress that's been taken to date, very much led by Kerry Harris, our head and lead for equality, diversity and inclusion. We've established an advisory group. There has been cultural competence and training taking place, active bystander training. And I'm pleased to say that we also have an education and cultural competence session arranged for board in December. There's also detailed longer-term commitments through the people plan, which we agreed earlier this year. In developing and consulting on our local health board action plan, there are some additional points of clarity that we need to take. You will see within the papers that there are timescales contained within Welsh Government expectations. Some of those have passed, so we need to understand what that looks like moving into the future. Some of the actions contained within our 5 critical areas are for delivery to partners such as HIW and other colleagues who are working very closely with Welsh Government Health and Social Care Services to understand what that looks like moving forward. And our support then be in terms of making sure that we fully understand what is the role profile of our ambassadors and our champions. What does it look like in terms of reviewing our policies and procedures through an anti-racist lens, noting that many of our policies are all Wales policies, for example. Those are just some key additional points of clarity that Kerry is working through. And the purpose of bringing the paper to boards today is really to highlight the work which is underway, the consultation on our local action plan, and also to ask for support on a number of issues which are outlined in this slide, noting for the action plan to have the best chance of success, leadership and visibility will obviously be key. So support really from the board in attending the session we've planned for December. Our plan is to move forward with board champions and ambassadors, not only for race, but for other protected characteristics in the future as well. We will be looking to implement a reverse mentorship scheme, and we will be happy to support that. And really looking at supporting our staff who are engaged with our race advisory group, who maybe wish to be engaged with that group or represent through our various staff networks in the future, that we support the time and protected time for them to attend those sessions, so that we can listen to the voices of our staff. Happy to take questions.
Thank you.
Questions?
Teach.
I don't have any questions, it's just a comment. Very much welcome this, and I urge the board to drive forward with courage and curiosity and conviction, and also to be brave around tackling whataboutery, because you mentioned the other protected characteristics, and frequently, and it doesn't matter which of those we're talking about, frequently people will wheel out the others and say, what about that? Yeah, it's strong, this, and we need the courage to continue with it alongside balancing work on the other areas of inequality.
I think key to approach will be recognising the intersectionality.
Absolutely, I want
yes, so people to inform into the run. And we're also very conscious that we'll be replying to do that similar.
Yeah, you know, we would say there's a cost attached to this, but there's nothing in it to say exactly what that comes to. But the other one actually, something that keeps coming up in every other report, and there are training groups out there on quality, etc., etc. Do you have any stats on that? I think it's in the report. Actually, it is at the moment. If we're introducing all of this, and this new stuff, and how much of the old stuff, if you like, is actually being adhered to?
We will have stats as being very component. So all of the incidents we need to delve into the specific training process. We will need to cost specific things. That is very much up to the consultation process. Bearing in mind that some of it we will to put hard figures on to, some of it we won't be able to, and we organise staff we need to engage with the connections and the
Well, it's sort of a wider question, expanding on. It's a bit like the research and development, because we see it as a bigger picture of retaining and recruitment. I'm just wondering, have we put, as a board, have we put enough resources into our equality diversity section that we, because at the moment, as far as I'm aware, it's just one person that does all this bulk of work, and it's enormous, the work that we're undertaking, and it is crucial to our recruitment and retention of our staff. I just wondered if we're missing a trick here by not actually putting more resources into this particular agenda. And this itself is a big piece of work just for one person. I'm just wondering where our thoughts were on what direction we're taking in building a better and more sustainable team.
With our companies, I think Ken is very visible organisation and has done a tremendous job in the time which has been here and taking forward this agenda. And I think though the responsibility for equality, diversity and inclusion is across a number of our portfolios. And so I've had discussions on the past year and the journey around how we might look at that. Looking at where our resources are and looking at that might mean how we join this work up moving forward. And so I think that's a considerable that we need to undertake, and then we need to decide what our overall support looks like moving forward. We are typically looking at the agenda. It may not be their whole job, it might be part of their job. And good point is the work for us to do to look at doing that. Yeah. I'd like to highlight a couple of points which I know Kelly was highlighted. It was a point, and so I think we will comment about our strategy. And so Kelly has supported the health board to secure external funding in the region of £40,000 to develop project which will go into the scheme, which will be engaging our staff to develop an arts programme or Black and ethnic minority logo and national icons, which will be visible as be able to be shared across the site.
Great, and I think we can all agree that Claire's been doing a really exceptional job. And I think the active bystander training is an improvement point to note as well. Something that's probably worth noting is the engagement forums that have been mentioned. Highways England, I think it is, have found that extending membership of those forums to more than just minority groups, smaller groups, has been really helpful. And you mentioned the research, it's also a good cost of things, but there's some really great stuff in here. Are there any more comments on this?
So there's a few points out there, whether or not we agree to support an anti-racist plan, which I'm sure seeing lots of nods around the table. And at some point, we're going to have to look at board champion role and the executive role as well, which I'm sure will sit either with you or Kerry. It doesn't ask us to make a decision today, although I'm sure that there will be a lot of hands going up around the table. And also to attend, really, we want just a commitment that everybody's going to attend the December training if they possibly can. And I don't think there's anything else in the paper if people are happy to approve.
The date for the training.
Do we have a date for the training? 14th?
Yeah, provisionally the 14th.
Provisionally, I'm looking at. Okay. Provisional date. And I welcome Anne back to the room. And I'll pass back to Anne for the next item, which is the staffing levels in the presentation.
Thanks, Evan. Thanks very much, Bevan, for standing in the vote. Could we go on to 4.1 nurse staffing levels Act Wales?
So I'll just preface this, but Linda has joined because Linda has done the majority of the work. So thank you to Linda. As you know, this is a statutory requirement in Wales. It is an assessment based on the quality, safety and acuity of the patients. We have noted an increase in the acuity of those patients, and this paper really set out the increase in staffing that we will be looking to secure to ensure our patients remain safe. But clearly, there is an associated impact on our agency costs. Linda.
Thank you, Chair. Thank you, Jenny. I think we're all very familiar now with the Nurse Staffing Levels Wales Act and the expectations as a health board. So I was just going to keep this, just to keep to the pertinent facts around it. The legislation surrounding the Nurse Staffing Act requires an annual presentation, hence the presentation today, specific to the wards under 25B of the Act. But just by way of reminder, we do have, we must have due regard to all our areas where we provide nursing services under Section 25A. The presentation report details the method, output and conclusions and actions that have arisen through the recent autumn nurse staffing recalculation of our 25B wards. You'll see from the presentation 14 wards require amendments, of which 12 require an uplift to be applied, and the cost associated with each ward can be as represented within the report. The required uplift is currently being met by variable pay, which is costly, and also there are some. We do have some concerns around the continuity and care and quality of care, where we do not have a substantive staffing workforce. In order to convert the variable pay to substantive staffing, I think demonstrates the Health Board's commitment to taking all reasonable steps to meet the requirements of the Act, and most importantly provides, as I said, continuity in care and providing safer quality of care to our patients. You'll see from the paper the cost to appoint substantively sits around 1.224 million. The current spend on temporary staffing from month 1 to 6 is 6.1 million, with obviously an expected increase in that looking through to the end of the year. There's a very clear expectation that temporary staffing costs must reduce as substantive staffing are appointed, and the Health Board Agency Reduction Plan and Project Board will ensure appropriate governance and arrangements are in place to monitor this. Therefore, the ask of the board today is to acknowledge the Health Board is meeting its statutory requirement to calculate their staffing levels for all wards under 25B, agree the substantive staff funding required to meet the Health Board statutory requirement of 1.242 million, and note the expected reduction in agency costs as a consequence. Thank you, and happy to take any questions.
Thank you, Linda. That was very helpful. Are there any questions?
It's the issue of the 1 to 6 million, I suppose, the agency costs, really, isn't it? As to what can be done to mitigate or reduce or what obviously that's a significant amount of money.
Yeah, so we're basically incurring this spend now, as was mentioned by Linda. So this does align with the reduction of variable pay savings program that's been established, and this is one mechanism where we can put substantive posts in and release that premium. It's a statutory requirement. We have to do it. We have to establish funding for this and budgets. That'll be form part of our IMTP process. It's part of our commitments going forward. But on the basis that we need these staff to be in place, this is actually a positive move, or would be a positive move once we see the recruitment take place and the agency premium start coming down.
If I could just add that this is one part of a piece of work that Sarah and I lead around reduction of variable pay, because we know that the quality of the agency staff is not the same as our own staff. We know that the impact from an emotional health and wellbeing perspective that has on our staff and our patients. So I think this is about levelling. We've been through a really robust governance process with the divisional nurses to really test this. And there are a number of other initiatives that sit in various parts of 6 goals and our broader work, which really focus down on that variable pay issue as well as this.
Thank you.
Leanne?
Just, I think, to echo some of the points that have been made already, as sort of the main budget holder, or sort of, well, actually the sole budget holder around sort of this spend, really welcome the ability to substantiate sort of, I guess, sort of significant costs we're already incurring. I think that they will absolutely sort of reduce, but notwithstanding, I think Jen's made the point around the quality aspect of it. Having temporary staff on those wards will have an adverse sort of impact, and actually some of the improvements that we want to make that will, in time, in my view, sort of actually shrink our bed base, I think will be fundamental to having substantive staff that know, own and lead the improvements and processes we have on the wards, and I think we can only do that with substantive staff. So just to give my full support for this.
Well done.
Sarah?
Just to follow on from Jenny's points, really, I think it won't be easy to recruit more. Really, is going to be around 300 registered nursing vacancies, but we have still to see some very qualified recruits come into those numbers. We still to see a programme of work in terms of overseas recruitment and developing that for next year potentially. But just to reassure, there's a large focus of the agency reduction plan, and also is contained within the paper that we're considering now is around retention of our staff as well. So we're looking at it from all of those perspectives, but acknowledging that but there is a considered piece of work underway to support it.
I think it's only fair to ask, what is the level of risk of our not being able to recruit and therefore still maintaining the that level of temporary staff because we have to meet these levels, do we not?
We don't have to meet the levels. The key piece of work which Jenny and I have spoken about and Linda is working on with colleagues in the workforce division is around a longer term strategy for nursing recruitment. So that we can forecast, at the moment we forecast around a 12 to 24 month period. We want to be in a position where we're forecasting more medium term. And we're building into that. So the work is already ongoing, we're building into it more robustly, a very focused plan in terms of how we see overseas recruits, and importantly, how we see our 100 or so healthcare support workers who are training to be registered nurses with us right now, coming into the numbers, and how we look to develop our apprenticeship schemes, which have had a successful start. We need to grow at pace really. So that will, I think, be available early in the new year, and we'll look to measure the risk as well as the opportunities.
Thank you. I think it needs carefully tracking through different culture. Please. Just to add to the point that the majority of the 1.2, there are some RN vacancies, which say that's right, you know, we're working through, but a huge proportion of it is around healthcare support worker, increased establishment, which we know we're spending £1 million a month on agency healthcare support workers, in addition to significant amounts of money on bank. So, you know, I think it is a low risk in terms of, as we said, address the quality issues and the morale issues having this high level agency has on board. So it really fits in nicely with our financial plan as well as our staffing plan and our quality plan. So they sit well together. Linda?
Just briefly, Chair, just a couple of things to add to that, I think, because I do appreciate the risk. And we are looking at a couple of different models of care as well, which will hopefully address some of our staffing issues. So, for example, with the COVID restrictions slightly reduced, we've introduced an enhanced level of care facility at the RGH, which makes sure that we can have the appropriate staff with appropriate skill mix to care for these patients. Also, with the new facility for our delayed transfer of care patient, we'll also be looking at clearly a different model of care around these patients. Just very quickly as well, our streamlining for registered nurses has improved significantly this year and again in March, and we are very much focusing on growing our own. So looking at our career framework for healthcare support workers and really encouraging our healthcare support workers to enter the health board with the opportunity of hopefully progressing through to registered nurse training. And we're also focusing on the career pathway of our healthcare support workers from 2 to 3 to 4, because the focus really must be on retention of our staff. That was just to add.
Thank you very much.
Thanks very much. So can I just add to what Linda said, the other bit within the workforce strategy, we'll be looking at how when nurses reach registration, we again have a retention strategy, which is about creating an environment they want to work within that creates the opportunities within professional development and clinical career framework. So we're retaining those people because they can see a path in AB for themselves and their future career. I think that's really important, is that when they step into registration, we absolutely do all we can to keep them.
Yeah, just the Nurse Staffing Act wasn't really about money, was it? It was about improved standards.
Yes.
And I think sometimes this discussion, the annual discussion that we have, tends to get lost in the monetary debate. And I would just like some assurance around the fact actually that you would expect standards to have markedly improved, because if they haven't, notwithstanding the recruitment issues, then you would wonder why we've had the Nurse Staffing Act and why we spend so much extra money on it anyway. So I'm sure the answer is that yes, standards have improved, but it would be good to be hearing that as well as the difficulty.
I think Linda's desperate to say something.
Only just to Only just for assurance, but we do track all the quality metrics around the 25B wards. I appreciate that doesn't tend to focus on the November report, but through our annual assurance, we track all our quality metrics aligned to 25B to ensure that we're not seeing any increase and hopefully a decrease in things like our pressure ulcers, our falls, our concerns, our complaints, medication errors. So we do track that, and we've got a database already aligned through the DATEC system to track that.
But also shortly be able to compare ourselves nationally in Wales.
Yeah.
So to look at that comparison around safety and quality nursing care across the wider structure of Wales, which I think will give us some benchmarks.
Yeah.
Let's just put that in the report next year then.
Well, I will. I'll make sure I do.
No? Might I suggest we break for a quarter of an hour and then return? Please.
Thank you.
Thank you.
Great, thanks very much. So next item, the agenda is Sarah. This is going to be your last annual report for us.
Thank you. There are 4 slides which have been something to bring them up. But I'll just start. So for my last report, I covered in 2019, and that was Building a Healthier Went. And there's been a hiatus between then and now, and that I haven't published one since because we've been busy with the pandemic. So for those board members for whom this is a new item, the Director of Public Health has the unique privilege of producing an independent annual report, which, if you think about Chief Medical Officer reports at national level, it's a assessment of the state of health of our population and recommendations about things that the evidence suggests should be happening and aren't happening. And so the report is, as you can see, it's for discussion, but it's not for approval because it's mine. So I just thought I'd explain that. And it is 175 years since the first medical officer of health in Liverpool. And the tradition of medical officer of health reports goes back a very long way. And they're an amazing historical record of progress over time. So that's the background to what my annual report is. And then this particular report, as we've said a couple of times, this is my last board meeting, and my team asked me to write down, I think the words were write down what you say. And so the reason it's coming today is to actually consolidate into one place things that I have said over the last 3 years. For members of the Public Service Board, there will be very little in here that's actually new, because I've taken a series of papers through the Public Service Board that has led to the decision for Gwent to become a Marmot region. But this is about providing Public Service Board organisations with a synopsis of all of that, and also some suggestions about what organisations can be getting on with, while the wider piece of work is done to develop the wellbeing plan and the larger report we'll get from the Institute of Health Equity. But I know our chair and chief exec are keen that we do some doing, and this is very much about what organisations can be doing because the evidence is there.
I don't know. It's on Do Not Disturb. I'm so sorry.
Ringtone. Anyway, I wouldn't know how. This is deliberately written as a guide for organisations that make up the Public Service Board to inform particularly the next year's plans, and also to start to align their thinking to the Marmot principles. And I'll come into that in a bit more. Through the report, we are publishing it on the website next Tuesday, when we'll have it in English and Welsh, and there are a number of links embedded in it that link to the picture, which is the MARM launch, but also to other things as well. I could have the next slide, please. I structured it at the beginning like building a healthier Gwent, which starts off with the challenge in terms of our population health. And unfortunately, the news is that the gap in healthy life expectancy for women has actually increased and is now 20 years. So for the Chief Executive, we've updated her favourite infographics throughout the report so that she can use them in her presentations. And so although this one might look familiar, it's actually the latest data. And what it tells us is that the gap between men in healthy life expectancy has remained about the same, but has widened for women. And therefore, for women, that in our most deprived communities, they are living 61%, 2/3 of their life in good health, and the remaining part in increasing health. For men, it's better. And I think one of the questions which I haven't answered in the report, but I think is something that needs to be done, is understand why the health of women in most deprived communities is seemingly going in the wrong direction. And I know that Professor Sir Michael Marmot and his institute have been looking at across the world. So I would expect their report to contain much more analysis on that and thoughts about what needs to happen to improve it. So the challenge, the inequities, I'm afraid, have widened as the direct and indirect harms of the pandemic and now the cost of living crisis. I could have the next slide, please. Thank you. So the Marmot principles, originally, the first 6 were published in the original Marmot Review of Health Inequalities in England in 2010. And they essentially take a life course approach about giving every child the best start and enabling children to develop and find good work and have a healthy standard of living as adults and live well in their communities. In the latest reviews done both immediately before the pandemic and then in 2020, so Michael has added some principles. So there's greater emphasis on the role and impact of ill health prevention, but also the new ones around tackle racism, discrimination and their outcomes. And it is good that we improved our strategy earlier today. And then the second one there around environmental sustainability and health equity, and the fact that those who are least able to adapt will be those who are most affected by change, and that's generally true of all of the threats, isn't it? That those with the least are also less well able to adapt. So I think for us as a health board, and Chris and I have had a few conversations, these principles align very well with the life course approach of our IMTP, and I think there's an element of just adapting some of our wording in the line of this commitment, but fundamentally we've already taken a step in the right direction. Next slide, please. So the structure of the report is the challenge and then the principles, but then we've written a chapter for each of the principles with a bit of more context, but importantly, case studies of things that are already happening in Gwent that could be copied and amplified by organisations, and deliberately written for organisations in Gwent in terms of informing what they can actually be doing. And the next slide, please. So there's a chapter for each. There's a summary at the end with the key messages. And then at the very end, there's a very short clip with my reflections. Thank you, I'll leave it there. We take the slides down.
Thanks very much. Do people have any comments or questions for Sarah on this report?
What I just say, I think it's a hugely impressive document. The Marmot principles, and I think we all applaud immensely. You've been the champion for this. What about the next steps in terms of it's been approved by the Public Service Board? I think just talk us through what you would anticipate happening, say, the next 6 to 12 months.
Yeah, so the primary reason for writing the report, which I'll be taking to the Public Service Board in December, is to give leaders and chief executives a document that they can share with their organisations that is hopefully easy for everybody else to understand, and with those practical examples in them. Following on from the launch, the programme team within the public health team we know what the corporate planning dates are for the 5 authorities, and the team are engaging with them, and Stuart Bourne in particular, I wouldn't have got this far without him. He's attending a number of local authority senior officer meetings around their planning. So that's the immediate first. And then in parallel to this, the wellbeing plan consultation, which we're coming on to with the PS3 update, there's a workshop on the Marmot principles and how people are getting organised to deliver on them. So the feedback I'm getting is that this is starting to permeate through. People are thinking about them, and they are starting to think about how they can align along this way of thinking. So the wellbeing plan is important because it's a legal framework, but then there's the process and governance underneath there that actually needs to permeate into the organisation. So that's the leadership bit, but then there's also the officer level bits that people actually are engaged in with sound, which is where the workshops come in. And then through the Integrated Wellbeing Network programme, we're also running community engagement sessions as well. So it's the idea of the report is to hopefully give something that supports the conversation without me being in the room. And then in terms of the appointment of the new director of public health, we have spoken, and I know that one of the things that has attracted her to apply was the Gwent Marmot region programme, and I have a lot of confidence that she will fully embrace it.
Excellent. Thank you very much.
That's great. Thank you.
It's excellent. I'm just reflecting back on the previous few years that I've been here as an independent member and how far we've come in the thinking. And it's quite a few of those things that we've thought intuitively affect the public's health weren't necessarily dated in the way that they are now. I just think it's led quite a sea change in the thinking. So congratulations.
Yeah, I just want to formally thank Sarah for putting the report together. I always enjoy reading the director's report. I think it's always well read. It's easy to read. It's very engaging for any member of the public to read it. And I think it builds on well from the previous one, and I think sets us up now in terms of moving forward. And as Sarah said, I'm quite keen that through the PSB and with the partners that we can focus on some of the things we can start doing, recognising it's a longer term strategy as well. But I think Sarah's placed us well now in terms of moving forward. So thank you as well personally from.
Okay. If there aren't any other comments, I want to thank you as well, Sarah. I think it just lays it out so clearly, and it's a real legacy for you. I think your last annual report, that you leave us with something so well formed, and that gives us a real platform to move forward in a way that we can actually try and support our population in the best way possible. And we know we've got a very mixed population, and I think the report reflects that as well. In how do we manage to get the best for everybody within our population, rather than just concentrating on one area. So I want to thank you for that. I also want to apologise for my phone. I obviously discovered that Motorola do not disturb setting doesn't seem to work every time. So I do apologise for that. But thank you very much, Sarah, and thank you for the comments, everybody. So if we move on to the next item on the agenda, which is the performance and outcomes report. Called to do that be you, Chris?
That's me, yeah, that's me. So thank you. So this is the second time we've produced the report in this way, which is really trying to give a more rounded approach to our performance reporting and move towards more outcome-based approach to talking about doing the organisation. I've been following on from the Director of Public Health, because we are a population health organisation, and we're trying to reflect our understanding of the impact of having an organisation, that population health impact, are being much broader than simply looking at the traditional NHS performance measures. So still looking if people want to feedback on the approach and styles. The second time we've done it that way. So comments on the actual style report, welcome if you want to drop me a note afterwards. And the way I think we present this report is kind of 3 chapters really. The first bit about what's happened in the last quarter. The second bit is about what are we doing about what's happened and that engine room we're using through our Clinical Futures programme. And that last chapter then is in terms of our profiles and looking forward, what does that mean and what's likely to be the impact of activity and output in the next quarter. That's the way I think about reading and presenting this report. The first few things just to reflect on, I'm not going to go through it lots of detail, but there is lots of really good progress in there and lots of things we've done and have achieved in the last quarter. So actually there's some really good organisation and a real focus around some of our longest waiting children as well. So I know that was a concern of the board following recent board development sessions, but actually you can see that improvement in the output and that concerted focus in children in particular. You can see improvement in some of our diagnostic performance. A lot of that is driven by additional insourcing and outsourcing of activity, particularly around cardiology and endoscopy, but you can see the waiting numbers coming down. And across all our areas in terms of activity has increased in the last quarter. So we are getting back to those pre-pandemic baselines and beyond in some areas. So you can really see activity ramping up. That doesn't mean we're not without challenges. We've still got non-waiting challenges in that area. The other thing I think reflective of this report in terms of the progress we're making is we're still making progress at the strategic level as well. So as well as representing the pressure that we've got at the system and the challenges we've got in the immediate, we've still managed to achieve some big ticket things around our strategic direction, particularly in terms of our enhanced local general hospitals. So the work on the breast unit at YOF has commenced. The full business case for the satellite radiotherapy unit at Neville Hall has been submitted to Welsh Government. And as Sarah has just been described, the work we're doing around the Marmot region is really taking effect. And that's really important as part of our role as a strategic organisation that is responsible for population health. And the report as well, we're trying to be really transparent and honest about the challenges we have as an organisation as well. And there are some challenges you'll see in the report. So particularly in planned care at the moment, there's lots of areas where we're making progress and you can see the improvements in our performance. But we know there are particular challenges, particularly around ENT services, around some of our eye care services, so particularly people waiting alongside for cataract procedures, and in some of our orthopaedic spines as well, are probably our biggest challenge areas in terms of planned care. But there's concerted effort and action plans around each of those areas as a focus. And in particular, as Nicola said in her report right back at the beginning, work we're doing with partners across the South and Cardiff around additional activity to support and bring down cataract. Reflected in the report as well is the challenges we know we face around in our cancer services, where actually there's been really good progress through the Cancer Board in identifying some really clear actions that we need to take. And we're seeing that start of that improvement trend in cancer services and cancer improvement. Still a long way to go to get to the targets, but it feels like we know where the challenges are in those particular pathways and we're starting to see that improvement. And the other particular challenges are those that are familiar to you as board members. So continuing to see our community beds occupied and that pressure that we haven't been able to step down, particularly that surge capacity in our community beds in particular, as well as the pressures that we've got in urgent care. And there was one other challenge I just wanted to mention that you'll notice in there that we had moved to a new system in mental health, some other areas, the WCCIS, the WICIS system, which you'll be familiar with from the process of implementation, which means we haven't been able to do because of an issue with the system, we haven't been able to do our required reporting on part 1 of the mental health measure. So there's some rectifying actions going in about getting that reporting back and trying to get that reporting back online and pieces of work around that. But I do need to report to you, we haven't been able to do our duty in reporting that measure because of an issue with the WCCIS system. And then the final thing I think I'd reflect on in presenting the report is what we do as part of our planning process is look forward and project our performance and then look at our activity against that performance. And actually, the profiles that we set ourselves at the start of the year and then refreshed at the end of the quarter, actually, we're holding ourselves more or less to our delivery profiles. There's a few areas where there's particular challenges, but I think it represents that actually we are being transparent about what we think we can deliver as an organisation in terms of output, and we are holding ourselves to delivery against those profiles. Those profiles don't go far enough and fast enough. They don't get us to achieving the targets that we would like. But actually, that's quite important with our staff, that we're having honest conversations about what's realistically deliverable and holding ourselves to that realistic delivery. That's all I was going to say in terms of overview.
That's great, thank you. Do we have any questions or comments on this?
Do we have any estimate of when we're likely to get data out of WICIS to support reporting?
Yeah, so actually, we've seen last week, and it looks like it's been a really challenging situation. I think that the learning that we've had now is most of the system errors have been corrected, and now the issue is about a really backlog of activity that needs to be put on the system to support us to be able to report. People are talking about several thousand, thousands of individuals who need to be updated on the system. So the conversation that we'd last is whether we can do it in a few weeks already to enable us to start really reducing reporting some areas. And we are pulling that together this week to be able to share with the delivery unit for a discussion. So I can't give you a different time scale today. We could obviously share a note afterwards if that would be helpful for all members. That'd be helpful.
Thanks, Chris. Any other questions or comments on this report?
I think it's very thorough, and the whole format of it and the informatics success, I think makes it,
Yes, that was something I was going to comment on. It's definitely an improvement on the old way of reporting. It makes it, it brings it much more to life, and it allows us then to get the assurance that we need from it, which I think is important. If there aren't any other comments at all, I'm sorry.
Sorry, I was just, I can't find it exactly now, but at one point you're talking about follow-up appointments. Obviously, follow-up appointments can be a whole variety of reasons. And I wondered what processes are in place to make sure either people aren't deteriorating, waiting for a follow-up appointment, or perhaps don't even need the follow-up appointment. And it's a huge issue, but just
Thanks, Helen. It's a really good question, and we can't forget the patients on the follow-up. It's just not just the new patients that present to us. So there's a really comprehensive programme of work around our outpatient transformation, as you'll be aware when we presented previously on planned care recovery. In particular, there's a focus on symptoms and patient-initiated follow-up as well. So actually, those patients that are on the follow-up list are only those that need it. Really good example of that would be rheumatoid arthritis patients, actually having access to a helpline when there's a flare-up rather than actually being put on routine monitoring. Just as an example, and I think just to reinforce delivery on that, we've just moved 4,000 patients off the follow-up waiting list for major joint follow-ups as a result of patient-initiated follow-up processes and changes that we've made, with more to come as well, actually. So there's a very discrete and targeted piece of work around those two areas of work in particular. The clinical review of those patients on the follow-up is a challenge for us, because if we keep reviewing without actually seeing, we lose capacity. And I think the balance for us around capacity versus the clinical time and assessment is a fine one for us at the moment, because we're so capacity short. But notwithstanding, the teams have clinically assessed and have cohorts of patients that they consider to be higher risk, and those patients do take precedence. And when we go beyond particular target dates for follow-ups, that information that teams will be aware of and have the ability to review and keep under assessment, sort of dependent on their clinical judgment. So that clinical prioritisation does take place, notwithstanding I think there's more work that we can do on that front.
Thank you. I mean, I think of course it relieves pressure on these as well, doesn't it? Or certainly we used to follow up unnecessarily.
Yes.
Isn't it? So I suppose it's refining and defining who needs actual follow-up these days, rather than the old system. Yeah, well, you need a follow-up appointment. In fact, you probably didn't need a follow-up appointment. So hopefully it's an opportunity to redefine what needs follow-up and using resources in the best possible way. Thank you. Piece of work around that, I imagine, in terms of making that determination. Are there any other questions or comments on this for Chris?
No, I was just going to say, I just wanted to say thanks particularly to, I know she always watches back the video to see what the discussion was, Jennifer Keat in the planning team and Sue Shepherd on the board team put the hours into getting this right and putting up with me constantly going back to them and asking for amendments and changes to make it look like it does. So
And the one thing that I will say as well is it's actually testament to the amount of information that there is in the paper that you haven't received a deluge of questions around it, because once the information is there in front of us that we can read it, it means that you get less questions. And so the two are linked together. So if everybody is happy, then I will move on to the next paper, which is the financial performance paper. Welcome back, Rob, if you would like to start.
Thanks. So the report presents the Health Board financial performance for 7 months to the end of October 22. In terms of key performance indicators, the front page identifies that the revenue year-to-date position is a deficit of 25.7 million, with forecast of £37 million deficit that we put in the Welsh Government. Capital expenditure is online to deliver within budget and in line with the plan. Public sector payment performance for the year to date is slightly under the target of 95% at 94.7%, but we are expecting the forecast to be fully compliant by the end of the year, less than 95%. And the underlying position is reported as £21 million deficit, and I'll come back to that in a moment as well. That's our opening position. That we were on the 1st of April as an organisation. We were aiming for an £8 million deficit as an improvement. However, due to the forecast deficit in reported, we need to revisit that. So key points to draw to your attention. In terms of the year-to-date variance, the deficit of 25.7 is in line with the profile that we issued to Welsh Government as part of our forecast plan, and the deficit was 37 million pounds, sorry. So it's a positive that we're in line with the profile, but obviously as a deficit is emerging, we need to do everything we can to improve that and make sure we continue to be in line with the run rate so we achieve the end point we're aiming for. In terms of income, I want to draw to the board's attention that we are reporting our revenue position as our core position, and the other elements of costs that are supported by non-recurrent funding from Welsh Government, which includes national COVID funding for national programmes like mass vaccination, etc., of £27 million. Exceptional costs this year, the Welsh Government have agreed to cover predominantly energy, £18 million, and the costs of the Health Board in implementing local service enhancements to deal with local COVID pressures and other pressures of £45 million. So they are outside of the core reported position, just to give that clarity. In terms of pay, our pay has reduced from September, but that's because September had a back pay payment. So if you ignore that, our run rates for pay expenditure are continuing to be in line with similar positions in previous months of about £63 million per month. That includes variable pay of approximately £10 million per month, and again that's running at the same run rate, and I'll come back to that in a moment. In terms of non-pay, we are seeing a small decrease for month 7 in relation to commission services and some CHC cost provisions that we were able to unwind. Our expenditure for the month was about £78 million, again, similar to previous run rates in expenditure. And savings, our forecast savings position is green savings of 10.2 million, amber savings of 12.9 million. And that aligns to the revised savings pro forma and programme that we had to establish to achieve the £37 million deficit. I move on to the forecast position. In terms of the revenue position, following the month 6 board meeting and finance performance committee, it was agreed that we would submit a deficit of £37 million on the revenue position for ABUHB for this year. An accountable officer letter was submitted, as Nicola alluded to earlier, and we've had a response noting that. That does assume that we achieve £16.6 million savings over and above what we previously achieved. And I've referred to that position just now. I'd also draw your attention to the underlying position, which I mentioned earlier. We've reverted because of the financial position emerging as a deficit. We've assumed that we will not improve our underlying recurrent position for this financial year. As a first step, we've reverted back to our opening position. There is a significant amount of work that needs to be done to just test where we are with our plans ready for the IMTP for next year and assess what our underlying position may be going into next year. So just for clarity, our underlying position is our recurrent position at the 31st of March that we're aiming for, which will be the 1st of April position that opens next year. The other key point the board is aware of, identified in the report, is the deficit of £37 million does relate to expenditure we're incurring to a degree, and we will need cash cover for that over and above our normal cash levels. So in terms of how we get that extra cash, we need to put a request in by an accountable officer letter for strategic cash support from Welsh Government. And as part of this paper, the board is requested to approve that letter is formulated on the basis of month 8 reporting, which we're going through in the next few days, and that we'll submit that to Welsh Government on behalf of the board through Nicola's AO letter. In terms of operational drivers, I'm conscious we've touched on a lot of these already in the previous report on performance. Let's say costs are broadly in line with similar run rates. In terms of pay and workforce, we're obviously seeing continued operational pressures from COVID, urgent care and bed pressures that we have to service. Enhanced care continues to run at a very high rate. There's a table in the paper, but if I draw it, the Grange has 40% of its patients requiring enhanced care. It's a significant burden on the organisation. And variable pay for month 7 was £9.7 million. There is a programme to improve our cost base for variable pay and looking through a whole range of issues to improve that. And that was touched on earlier. I would say, however, that our winter plans may potentially have an impact in terms of getting cash out from those savings initiatives because we're also dealing with more pressures during winter. We do have £2 million on top of RPB funding built into our cost forecasts, which was previously identified in month 6, but we just need to keep a watching brief on that. However, actions are progressing to make improvements on variable. In terms of non-pay, we have seen a reduction due to commission services forecasts being reviewed and revised, and we've been able to reduce some of our provisions for CHC placements for the year. Placement numbers for CHC have reduced from 678 to 665 in month. There's further detail in the paper. In terms of beds, we've had additional capacity open of 142 beds above plan during the month, and we continue to have significant delayed transfers of care. And at the end of October, to match with the financial figures, that figure was 292 beds with approximately 50% being social care related reasons. RTT activity continues to be delivered, and Chris touched on that just now, so I won't repeat that. Savings, as I said earlier, we've got £10 million identified as green savings, approximately £13 million as amber, which we need to deliver the full £23 million savings target, which takes us to the achievement of a £37 million deficit, which is our maximum limit, if you like, agreed with the Welsh Government. In terms of risks, several are noted. They're related to the securing income. So the Welsh Government have undertaken to support us with the non-recurring funding as identified earlier, but we haven't actually received it yet, so that's why it's flagged there. Savings, as I say, we need to convert amber to green. Spend, we need to just keep a watching brief on that very carefully to make sure that our actions to reduce costs aren't replaced by other pressures, and we identify mitigations wherever possible. Again, operational delivery, particularly through winter, is going to be a pressure for us and a risk for us. And the recommendations are noted in terms of the report, the key one being the request for the AO letter for strategic cash.
Thank you, Rob. Are there any questions to Rob? Bill?
Just wondering about this cost pressure on enhanced care, so the 30% of patients in the range cost pressure. Is that cost pressure over and above what we planned for? Because I would assume that everybody in critical care sector would be so just wondering whether we plan for that or is it on top of what we that would be quite a lot of money. So.
Yes, so for the month it was £800,000. So I'm just looking for the page. There's a graph in the report that presents the enhanced care profile over time. And it had increased significantly since pre-COVID to 3 to 4 times the level we would expect. And that is an ongoing pressure for us at this point in time.
And one that is difficult to do very much with, I guess, then.
It is there. I think there's lots of contributing as we're seeing, as you know, it's been reported before, very significant pressures on our ED. That results in a lot of inpatient admissions for enhanced care. Enhanced care covers lots of different elements, particularly where patients may need one-to-one observation if there's a risk of falls due to confusion or other areas. So there's a wide range as well as just being particularly acutely ill. So, but that is an ongoing pressure for us, yes.
I just wonder whether at some stage it would be useful to have some kind of a document that tries to wrap this up through an analysis. I mean, we've heard about increased acuity, we've heard now enhanced care, all of these things. It would be good to try to understand why we were to try to understand the cost pressure. In a way.
Yeah,
I think it would be helpful to try to understand both what we're dealing with and where we're going. And then that leads me to my next question, which is about the position that we find ourselves in on the 31st of March. I mean, having not been in this position before, I don't know what the arrangements are. On 31st of March, if we report the 37 million, if Welsh Government give us more money, what do they normally do with boards who overspend? Do they give them the 37 million so that you start on the 1st of April from a neutral position, or do they carry the deficit?
So my expectation and understanding of what's been done in previous years with organisations is they will report a deficit. It will be a breach in one of the statutory targets. That's formally accounted in that way. So there will be an audit qualification on that basis, if that's the way we do it. In terms of next year, we will receive our allocation. That's due just before Christmas, I understand. And we will be expected to plan to live within our allocation. If we're not able to do that in line with our expenditure plans and savings and efficiency plans, then there's a potential for a multi-year recovery plan to be developed. But all that needs to be in discussion with Welsh Government. So we don't carry it forward, we sort of start again. That's the normal way that's been operated previously. But we do appear to be in an unusual year, an exceptional year with nearly all health boards overspending. And Welsh Government do need to identify how they, at their level, because all the accounts get consolidated up, how they're going to manage that. They could choose to, on the basis if they are able to manage that from a Welsh Government perspective, they could delegate funding. But I would expect they would probably just do that at the level above health boards because of the accountability arrangements. But that's something that we revisit as we progress through to the event.
So we could start the first of April with this 37 million deficit, but it wouldn't be called a deficit. It would just be something that's on the side of the account that would say, well, you owe this money, or you're in breach of regulation because of this money, but in reality, it would still be there against us. That's what I think.
Potentially, yes. I think I'd probably. Well, that's an interesting question. What I would probably say is it's reported that we overspent, but in the new year, generally it's a fresh start, and we just need to try and live within our means, which means making serious decisions between now and start of next year's part of our IMTP to work through how we actually do that if we're able to.
Thanks.
Just coming back to the issue of enhanced care, so these would be patients who wouldn't be critical care, they would tend to be patients who are being nursed on wards but require an enhanced level of supervision or care in some way. So most of these patients will have a cognitive impairment of some description that requires additional supervision. That we've got very robust procedures around the assessment for that, but we've definitely noticed a trend, as you'll see in the last paper, around the Nurse Staffing Act, around the increase in the acuity, and the acuity is mainly in the enhanced care patients. You could argue that probably shouldn't be an acute environment, so much of what James is doing around the redesigning services for older people. We'll look at how we support people in their own home. That will reduce confusion. And we're working very closely with Leanne and her team on alternative models of care. So Linda mentioned cohorting facilities. So we would care for these patients in a set part of the ward. So it will be designed for their needs. It's already successful in one of our community hospitals, and there's also some models in Swansea Bay around a different model of staffing to support these patients, which would be better for the patient, more cost effective. So there's lots of work ongoing, and we continue to review this.
Thanks for that. It's just, it seems to me that I'm sure we've got a good handle on all of this, but until we understand and analyze why where we are, it's very difficult to talk about, isn't it?
Yeah.
Because you've got to look at what's driving the power. And that's clearly what you do.
Yeah, it's to build on that in terms of the enhanced care is kind of one measure which is trying to capture the acuity increase that we're seeing. And it was only when you go out speaking to people, so in where we had yesterday, they were saying, BNP level of cardiology patient used to be X, now it's kind of through the loop like you've never seen before. When they come in with cancer, sometimes it's spread and it's riddled. When I went to YTC up in, they were talking about dementia patients, as we're not seeing people when we diagnose them, they're almost becoming a secondary care admission before we diagnose them when they're admitted. And it's been puzzling me in terms of how do we capture, when we're having conversations with Welsh Government and trying to understand all the pressures on the wards, is how do we capture that change in acuity? Anecdotally, the surgical teams have said when, get some of your surgical emergencies in, they're much more complex and developed than what, so I think it is all a post-pandemic impact, which I think we need to see for some time yet, but how we capture it with an evidence base is really difficult. And it is something for us to think about in terms of at a specialty level, are there metrics that we could use, whether it is what's people's BNP level when they come into an assessment unit, I don't know, but enhanced care is almost one measure of saying, because we give them it's basically going to give generally 1-to-1 care or 1-to-2 care. Yeah. A team of covering 6 beds or 8 beds just can't manage. So I think, you know, to see that at the Grange as well, as you said, which is generally a good, well-staffed wards, I mean, still, you know, especially with single rooms, we've got to be really careful about the supervision we provide some of these patients. But I'm not quite sure that we can capture it to the level that I think we witnessing to experience when we speak to clinical teams, because everyone you speak to says exactly the same thing. And I don't think we've got the measurement systems in place to do that, but I would like to look at how we could capture it, because I think it would be hugely powerful in understanding the pressures we're under, because it's not just about the numbers. Because when you look at basic numbers, even on planned care, they're a bit like, well, you know, why are your numbers, why do you do the same as you were before? I'm trying to, and even for ourselves, just to evidence that is really difficult, but really important, I think.
Well, I think at some stage, somebody was going to say,
Yeah.
well, what's driving this?
Yeah. We have to
Where you
say that
are.
it's all anecdotal, it's
Yeah,
verbal,
exactly.
yes, speaking to staff, but it's consistent, isn't it? Yeah.
I think it's just very briefly to build on the point that Nicola has made. So a very real example of that is a patient that presents with osteoarthritis into a theatre setting was waiting on the list for 6 months when they waited for 2 or 3 years. Is going to be a more complex, time-consuming operation. So I think there are some very discrete metrics that we can look at to give an indicator of that. But I think it's important as a board, and certainly all of the conversations we have at Wealth Government, is when are you going to get back to pre-COVID levels of activity or performance? And I think that actually is probably quite a difficult thing for us to do, even if we had sort of the workforce to do it, because of the complexity and difficulty and the pause in what I would consider to be routine healthcare during the period of COVID. So I think as a board to be mindful of, can we really get there? But we do need to evidence it. And I've had some conversations with James and Jenny about the adding in the enhanced care information to what's happening on the RAMI with some of the information in theatres, so that we get an evidence-based view of the level of care that we, to help us plan the level of care that we need to deliver in the workforce. We need to do that more appropriately, because I think it will ultimately boil down to some choices that we will need to make because of that complexity and difficulty.
Are there any further questions? I know that you've had a number of focus sessions on how to balance our budgets given activity. I think it'd be really helpful if, and as you've said, the areas of focus will take some time to come to fruition, that there is a detailed update to each finance committee, and if you could give us an indication as a starter at the next board briefing, that would be very helpful. So that we can all travel on the journey with you.
Yeah, absolutely. That's the intention.
Final comment, just on a positive note. So I think, you know, we've got a challenge to get to where we are this year. We're all working on it. The conversation we had with the wider senior leaders, which was about next year, how can we do things again? Because, you know, we think this year's difficult. I think next year financially is going to be extremely difficult, so we need to do things different. And the session we had with the senior leaders, we kind of used it as a bit of an, you know, thinking session, getting people's ideas of how we can do things different. And there was a huge range of ideas and opportunities that came out from ranging from, you know, reducing waste, where we know there's some obvious areas where maybe through COVID we've taken our eye off the ball, we can get back on, right the way to really working differently. And I, you know, despite all I was really encouraged by the session, and I felt there was a real energy and enthusiasm in them to work, you know, work differently. So we'll be building on that, but I just thought, on a positive note, in the spirit of, it's all a bit, you know, doom and gloomy out there, there was an energy to, which did make you think we have got opportunities as a health board to work differently. It's about how we get the pace and the headspace, which was some of our discussion, to free up the teams to be able to drive some of this. But it was definitely a whole range was there of issues that came out of just that an hour and a half discussion with the team. So I thought I'd just share that to keep our spirits lifted with this issue. Thank you. That's really helpful. Okay. If we can move then to the rest report, please. Yeah, thanks, Chair. So it's the standard report, and I think you can see from the report that we identified 7 additional risks, which is what I think we'll spend most of my time focusing on. That through the various committees and through the various executive team and portfolios, we've identified 7 additional risks. The other risks haven't really changed significantly since the last report. So the first one is around safeguarding, and again, another area where we feel we are seeing the consequence of what I presented in terms of additional safeguarding issues presenting to us. So not only the risk of being safeguarding harm, but also the workload that puts on the team and making sure that our team is fit for purpose to meet some of these increasing demands going forward, and generally continuing by looking at that. The putting things right, Jen's put on around is continue to sustain non-compliance with NHS complaints. This is an area that myself and Jenny have been particularly focusing on since I came into post. There is a backlog. It does worry me when I'm answering complaints back from July 2021, which there still are some of those. But we have, and also making sure the responses, because of the workload and the backlog and the time, the responses are compassionate, informative, comprehensive, and really trying to make sure that I'm person-centred, you know, and we're really trying to make sure that the response, but we have got some work to do around working for the backlog, and I think trying to get a more kind of person-centred approach to some of the responses going forward. So Jen and I are working on that, but it is important to raise it because there is, you know, when you really pick it up through various sources where there is some concerns about the complaints process and the backlog. But again, some of that is symptomatic of where we've been, but we are on the case with this one, I think. But it is important to be aware of that risk. Industrial action has been picked up. Obviously, we are aware of the RCN recent ballot where this health board was the only in other words, it didn't quite make the threshold. But it's not just about the RCN; it's all kind of and the risk of strike action that we need to be aware of, and the impact that could have on patient care, particularly planned care, and recognising the commitment to not affect and threaten services. The external escalation of displaced people. This is the increase in number of people coming to the Gwent area and to the Home Office commissioned accommodation, and just being aware of the risk of that increase in demand for our services. And have we got the capacity to respond to that? And I know we've obviously got targeted work going on with our teams in terms of screening, and as people come into the area, we've got a good wraparound service to support them. But it is making sure about how that could impact on the wider services and more directly in terms of primary care. The cost of living crisis we've talked about earlier, is particularly that risk of staff absence, but also the risk on the public's health if they are living in colder conditions. And the last one is around, but one is around the children's, the Eliminate programme, where Welsh Government are looking at unregulated children's placement. This is an issue we reported back previously that was discussed at the RPB, the real concern of the impact that could have on children's services, depending on how that is managed and how the private organisations respond. And then the final one was around the LINK programme. And this is the replacement of the LIMS pathology service, which expires in June 2025. The LINK programme has been the replacement programme. And this has been discussed at a high level, chief executive level, where there's been risk identified for that programme going off track. And there is a contingency plan being put in place, but I thought it was important. We all agreed, all chief execs, and this needed to go on all of our risk registers so that boards are cited. Because if we don't sort this out, there is a risk of our unsupported pathology system in 2025, which would not be a good place to be. But we will keep you updated on that as the national discussions progress. So there's 7 additional risks that we have said that we're making sure that we are capturing risk appropriately across the organisation and through the appropriate committees, which has been helpful, I think, in terms of alerting them. What we are keen to do is to be able to get some risks off the agenda or downgraded, and we're working hard on that. But a lot of them, I think, are not just relevant to this health board, they are wider system risks. Hopefully that's helpful.
Thank you, Nicola. Are there any questions on this? Ewan?
Just to one, I've been reflecting, as I've been here 6 months now, I've kind of reflected back on some stuff. We've got 4 risks that we manage within our tolerance level at the moment, which means there are, unfortunately, another 28, 29, there are risks outside of our tolerance level. I think it's a general question about how happy we are that the actions we've got in there will bring us back within that level, or whether or not we've set a tolerance level at the wrong level, or whether or not we need to put some more actions in to bring us back, and whether or not we bring ourselves back within an acceptable time frame. It's not an answer we can give now, obviously, but it is, to me, you know, it's an easy one. If something does go wrong, somebody comes in and says, well, you had that risk there for a year, you had these actions, but they were never going to get there, and it's an easy one to.
I think one of the critical actions is the need for the board to review its risk appetite statement. We've our risk appetite statement's been in place since before the pandemic. Clearly, the context in which we operate now is very different, and the level of risks we do need to tolerate and things change. So I think the tolerance levels are set at current appetite level, but the appetite level needs to change. So we have got a session scheduled with the board in February to talk about our risk management approach, our risk appetite statement, our strategy, etc. So I think there is opportunity for us to reset some of that. Absolutely, the committees need to be into the detail of the actions that have been identified and whether they take us far enough.
Yeah, I was going to say it's probably down to the individual board level committees to have a good look at their risks between now and that point. But the right actions in place, I guess, to get us.
So could that be a note to chairs, please? Yeah. Okay. Thank you very much. The Public Service Board update, Sarah.
Thank you, Chair. So the paper provides the board with a summary of the Public Service Board's last meeting in September. Of particular note is the draft wellbeing plan and the link to it for any members of the board who wish to look at it. And that is out to a 12-week statutory consultation, and the Public Service Board will then consider the results of that consultation when it meets again in a couple of weeks' time. As I mentioned earlier with the Marmot region, there are workshops taking place on the draft wellbeing plan that include the objective about reducing inequalities, which has been linked to the Marmot region programme. The report notes that the Marmot region programme was launched at the Lycett Institute in Newport on the 21st of October, and the event was recorded and deliberately recorded so that it could be shown in various lengths, bite-sized or longer, for people who weren't able to be there to support the discussion, and therefore the earlier item on the Director of Public Health report has got that there to share with people. I think the really important thing about the launch was that we had the leader and chief executive of both their three authorities and one or the other from the other two. The Police and Crime Commissioner was there. The Chief Constable had hoped to be there, but actually had urgent matters to attend to. So I think, and Nicola was there, and I think was a tangible commitment, which the Institute of Health Equity commented on after the event. And as we said earlier, it's about what's going to happen next in terms of doing. The humanitarian crisis in Ukraine was discussed, and we've just talked about that on the risk register. Actually, the Welsh Government has closed its super sponsor scheme for Ukrainian refugees, and I think, as we've just said, the bigger risk is the migrants coming in and the need for multiple places of accommodation across the United Kingdom to accommodate the numbers. And board members will be aware again from the news that when you put a lot of people who come from various places together in a crowded space, the risk of infectious disease is always there. So therefore it is important that we really provide prompt health screening and immunisation, as well as addressing wider health needs when they arrive with us. The Regional Scrutiny Committee was mentioned, so there will continue to be local authority level scrutiny committees, but there'll be a Gwent level scrutiny committee for the Gwent wellbeing plan. And Chair, you're much better placed than me to explain what our involvement in that might be. I know you're going to have further conversations.
Yes.
And then there is a review around the various partnerships that relate to the community safety agenda. And we have a number of things. We have the safeguarding board, we have the area planning board for substance misuse, we have violence and against women and domestic violence, and we have the youth justice board. And if you're the director of public health, they are all responding to the fact that the crisis has now happened. And what we seem to be missing is the where are we actually preventing that happening? And I think that's something that I hope will come out of this review that is being undertaken around that part of the partnership structures, because it's largely the same vulnerable population, and we seem to be addressing it in different bits of governance. So that is, I think, at the heart of what that review is about. How is it more aligned? And then finally, we talked about the cost of living crisis, and there was, I think, really the summary of that conversation was there is a lot happening at local authority level. It wasn't immediately obvious what could be added at the Gwent level, but that conversation will probably mature over time. So I'll leave it there. Thank you, Chair.
Thank you, Sarah. Are there any questions or comments to Sarah about the PSB? Once again, congratulations on pushing the agenda. That's something really. 7, the Regional Partnership Board update. Chris.
Thank you, Chair. So the paper provided an update for board members in relation to the current work programme of the RPB. A number of those areas we've already discussed this morning. So the one area that we've spent a lot of time thinking about in the RPB is development of the integrated winter plan. We have a paper around that this morning. And the other area of the RPB discussed at its last meeting was the NCN governance. Again, we've discussed that today. A couple of other areas maybe just to highlight for colleagues in terms of other areas the RPB have been thinking about. At the last meeting, we had a proposal in relation to a number of capital schemes that had been developed by each of the strategic partnerships, and the RPB supported those capital schemes to go forward for submission to Welsh Government. Some of the themes around those capital schemes, and there's quite a significant theme in relation to a number of proposals around increasing residential provision for children and young people within the West footprint. There were a number of proposals also supported in relation to further development of health and wellbeing centres as part of our place-based care model. And there were 2 capital schemes that were also supported by the RPB in relation to supporting increased provision of minor adaptations for people in their own homes in terms of aids, adaptations to support people to maintain independence. So all of those capital schemes have now been forwarded to Welsh Government. Probably the last thing to pull out is the RPB has requested a review of all of the 17 strategic programmes that are currently being taken forward within each of the strategic partnerships. And I think that review is around making sure that, where we're at this point in time, are they the absolute priorities for us, given the absolute challenges that we face? So that people yeah, as chair of the RPB, I'm not sure whether there are other things that you would like to.
Thank you. I think that given the content of our agenda today, we have to appreciate the growing importance of the RPB and the role that it is adopting and its remit, but also its responsibilities and the way in which it connects with the statutory bodies. And I think that that part of the governance is in need of strengthening, so that that the statutory bodies are well aware of what the RPB is doing on its behalf and can endorse it and take action when necessary. I think that it's becoming quite an active regional partnership board, but I still think we have some way to go in terms of ensuring it's fit for purpose and it's staffed accordingly, and it's more coherent and cohesive. So there is quite a work programme over the next year to consolidate the work of the RPB, and then it will be having to look further at how it connects with NCNs, etc., and what the expectations of government are for it under that consultation they had on social services in particular, and what they're going to ask the RPBs to do. So I think this is a period of change, but fundamentally, a review of the priorities that we're following, and the priorities, I don't know when they were set, 7 years ago, I wasn't here, so I don't know. But given the changing circumstances of the communities and the role and responsibility of the RPB, are they the right ones? Are we pursuing the right things and really focusing our resources on that? So there's a huge amount of work for the RPB to do to grow and develop, but also to really think very carefully about how it does its job and whether it's focusing on the things that make the biggest difference to the individuals that they're to serve. So we'll see what happens now over the next year. Yeah. Any questions on that?
I'd just say, Chair, it's an interesting beast, this RPB, isn't it, that we spend a lot of time kind of talking about. I think it's at times it's good to reflect on why we have it.
Yes.
We have it because, in essence, what government wants us to do in terms of health and social care is behave as if we were an organisation, without them having to go through all the trouble of making us one organisation. And it's very easy to say that, but it's very difficult to deliver it when all of the statutory basis of the individual organisations remain the same in terms of governance, in terms of money, in terms of everything else. So it's almost a voluntary kind of grouping, isn't it? That we need to run through consensus, and you do. I think you do a better job than I ever did in trying to get consensus. But really, if you look at what we should be doing, well, we should be really pooling our resources. That's what the RPB is meant to do. That's what's in the original document that created them. And we are meant to be, the idea was you would have enough senior people around the table to release blockages in the system. Now, if you look at what we've done, we haven't done a great job in terms of pooling resources. What we've done is done a fairly good job at being a resource panel. We've allocated money out to various initiatives, and those initiatives have generally been aimed at some of the operational difficulties that we've had, as opposed to trying to reorder the way we do our business, isn't it? And then if you look at the other issue about releasing blockages, well, for whatever reason, that's a subject that we stay well away from. I mean, over the last few RPBs, we've not touched the issue of the delay transfer problem at all, because we feel it's a bit too hot to raise, so we don't raise it. When actually, that was one of the fundamental reasons why government created it, with the various people that we have on the table. But I know all that sounded a bit negative, but I'm much more optimistic about it now, partly because before we talked about integration, but we've never had a service model.
Yes.
But I think now we have the beginnings of a service model through the place-based work. And I think really for the RPB, that is the biggest show in town. And I think in terms of the RPB, we've got to really push that, because that, I think, will provide the solutions that we're looking for. So I think, I generally think it could go in a much more positive direction. So I'm not as miserable as I've always been. I think it's okay. I think we can actually deliver something now. But it's a long way off it, but at least we've got something now to focus on.
Tish, as another member of the RPB.
I think following on from that, that, as you said, the aspirations were up here to make those changes, but actually what we're seeing is we have some glimmers down here that are being done out there and starting to demonstrate the concept, and that's hugely heartening. We need to pull that through, but when we reflect back on the conversation we had this morning about the new Port West, we talked repeatedly about evaluation and how actually it's quite difficult to pin down those benefits. And we did also talk quite a lot about that more subjective But we do also need the numbers. We do also need the value with those numbers and pound signs so that we can pull those through up to the decision makers and demonstrate the value of that different way of working. And that is where that cycle will be complete.
Thanks, Steve. Agree. Any further comments? Thank you. The Executive Committee Chair's report. Thank you. Yes, this is a kind of a newly framed executive team report. Thanks to Rani, who's helped pull it together. So we've kind of re-established executive team as the executive committee as part of our kind of professional governance. And it just kind of, we've been reviewing how we thought things were working and just refining those in terms of trying to make the most effective use of our time as an executive team. So in addition, we have once a week executive committee, which is part of our kind of formal business. And then to complement that, we've got some weekly informal executive team sessions, which gives us a bit of that extra time to, you know, really think through some of the tricky issues and have a bit more time rather than just kind of approving or doing formal business. On top of that, we've got the monthly clinical pictures programme board, and we've got a finance recovery and turnaround kind of board as well now, once a month after the month-end position, and then some executive team development sessions as well. We've structured the main committee into kind of key headings around quality, safety and culture, and as part of that, the clinical execs meet, and we also discuss in the weekly executive team briefing where we will consider things like SIs, serious incidents, measurements. We've now got to focus on some of the ambulance targets around immediate red release, and 4 hours will be added onto them. And anything that we should be concerned about, safeguarding issues, things that will come up that we discuss as an executive team. So really important part and an area of the executive committee that we want to strengthen and make sure that then feeds into the board as appropriate. Delivery, performance and efficiency, strategic planning, service development, partnerships, and some of the sectors, I said, of the transformational programmes. And the rest of the report just kind of sets out some of the key themes that have been discussed under those headings, most of which we probably covered at some point today, so I don't think I need to repeat, which is quite reassuring when I read back over it that we are talking about the same things. So hopefully this is helpful as a new report, which I think is supplemented by my own chief executive report, which is not generic. Thank you, Nicola. And yes, it is extremely helpful. It does coalesce with the board. Are there any questions for Nicola? No. An overview of joint committee activity. Yes, so there's a little bit more information now, I think, in the attached report, which is good because I know Rani was feeding back some of our previous concerns. It's there for information. I'll just draw out 2 areas that I think will be of interest and relevance. We had quite a detailed discussion when we met with WISC around paediatrics in particular and a concern around paediatric weight. So there was a fairly detailed discussion at WISC around the recovery, particularly around Cardiff and Vale's ability to get back to pre-COVID levels, which they're currently struggling to do. They still can only see a line of sight to 80%. So there's further work going on with them. And WISC also looking at what other opportunities exist outside of Cardiff, if need be, in order to address that. And I reinforce the views of this health board. And just for something for us to pick up another time, is we've been doing a bit of a focus piece of work in the health board around our paediatrics, because we've got lots of people on outpatient lists in terms of, you know, making sure what are the long waits for our paediatrics that we might want at some time in the future. But a really good discussion and something that's high on the priority agenda now for the next joint committee as well. And I'll keep a close eye on this in terms of what that means for our children in our population. The other one I just wanted to draw, there's quite a bit of work going on around the mental health strategy development. This is obviously in the strategic, the specialised elements of mental health services, and also a piece of work around the single commissioner for secure mental health services, you know, in terms of what an option appraisal of whether we should try to provide more services in Wales or whether it's not justifiable, but have we got the proper capacity in England, because there is capacity constraints in the system. You know, we've had some recent cases where, you know, people have had to go quite long distances to Scotland even in terms of accessing services. But it was an important conversation actually in terms of learning from each other about what work we can do to invest upstream to avoid the demand further down
further down the line in terms of people requiring, and there's quite big variation between health boards in terms of the numbers of people accessing specialist mental health services, where there's a variation in the prevention side. So some good discussion about that, some work that we keep, we'll be obviously involved in as time goes on. But I thought they were worth noting.
Thank you. Are there any questions to Nicola?
Nicola's mentioned safeguarding and paediatrics. I just wonder whether this was just mentioned in the report last week on the current time for case. I'm sure we are making that. Some pretty stark recommendations. So
Absolutely, and it's important to be particularly in any of these cases. So I think picking up a learning from all of those, any review that happens in health board and across the board actually.
It's an unusual.
Yes, it is quite unusual, I understand.
Any questions? Could I just ask about one thing, and that is the fact that WISC supported the appointment of a fourth thoracic surgeon post for Cardiff to support the major trauma unit. Now, as we know, we all agreed some years ago that thoracic surgery, after a major review by WISC, would move to Swansea. I don't know what sort of case has been made for a fourth thoracic surgeon in Cardiff. I know that when the major trauma unit was proposed and agreed, they were concerned about the thoracic surgical cover for a major trauma unit. But it seems to have escalated now to having a separate, in fact, keeping the state at quo and increasing the provision in Cardiff. Now, I don't know what the rights and wrongs of that sort of argument might be because I haven't seen the paperwork. I only saw the paperwork related to the original decision. But we haven't, well, or have we? Well, certainly the board hasn't had the official year one evaluation of major trauma. And I know it'll be an odd year because it was part of the lockdown and open up time in the pandemic. But nevertheless, I think it'd be awfully helpful to have some further justification of this because we don't want to deprive a major trauma unit of the services that it needs to run effectively. But we haven't had the evaluation of this board. And where does that fit with the decision taken some time ago to actually move thoracic surgery into one unit? Just a few questions that we might pursue you.
Yeah, I don't know if Robin was I know because we picked this up, I think, with WISC, is that some of the delay in centralisation of thoracic is linked to physical development and sorting, which I think is holding a bit. And there was thoracic surgeon components within major trauma, if I remember.
Yeah.
And there was quite a lot to work through in terms of how would that logistically with when
Yes.
thoracic services were centralised. But yeah, we can follow up some of those. I think Rob comments will be
Yeah, I think I believe the health boards have actually requested further information, so we should be getting that hopefully.
Okay.
I'm not sure what the timeline is for the formal evaluation of major trauma. We're
supposed to do it after
there was
a
a brief, wasn't it, Nicola, I think, in terms, but I don't think there was a formal report. I think there's a brief report, and so I'll see what I can find.
There was supposed to be a full report that we need to press forward because that was what was agreed.
Yeah.
After a great deal of debate.
Yes, I would.
Yes, I think we all remember. Okay, thank you. Thank you very much. East, oops, sorry.
No,
Oh,
it's
sorry,
it's
sorry.
not kind of thing. There was a report request. I was just going to say, because we actually have regional partnership, regional planning under the partnership population planning committee. I know we've got those tools. So we can bring the reports there if you like.
Okay.
We'll find out what it's going to take.
Find out what's happening and find out about this thoracic development, and we'll review it then at planning at the end of the month. Okay. Thank you very much. East, anything?
Yeah, nothing specific on East is what we've already been talking about, just to really focus on the ambulance delays. The only thing that's just worth again just noting is there is a renewal of the emergency medical retrieval transfer service, just in terms of optimising locations that's mainly affecting North and Mid Wales. Just to be aware of.
Thank you. Any questions to Nicola about it, East? Okay, thank you. Key matters from the committees of the board, 4.1. People and culture, anything to add, Louise?
Well, Nicola's already alluded to the risk that was brought up about industrial action. So that's on the corporate register. And also there was the nursing and healthcare support worker agency refusing to contract with the health board. And this element was going to be put in with the workforce risk alongside, as you've got in the paper anyway, the financial break-even risk. I don't know whether anybody wants to say or wants to elaborate on the second comment I made, but that's all we wanted to bring to the board as a committee. Thank you.
This is just a risk around us not being able to process the volume of incorrect invoices, I should say, were sent to us by our agency providers. But I think in working with Rob's team in finance, we're making good progress on improving the situation. So we're moving with that remains as a risk moving forward.
Okay, thank you.
And that would be the same with the industrial action.
Yes.
So near the time,
So, yeah.
and both could come off hopefully. So
Thank you. Finance and performance, Richard's not here. You and anything to add?
I don't think so.
Okay. Any questions on finance then? No. Audit risk and assurance.
Just the one small change to the paper, the external audit of the charitable funds. We expressed a disappointment to the auditors, they weren't going to get it in time. But I think they've now started, they've got the resource in and they're up and running, and hopefully everything will be done so that we don't get a nasty letter from companies.
Thank you. Okay, charitable funds, Tish?
No, nothing other than what you just said.
Okay. Good, thank you. Shared services.
Nothing to add other than I've participated more recently in a workshop with shared services developing their approach to their IMTP along with.
Thank you very much. Closing matters, any other business? Thank you for your forbearance today. It's been quite a long meeting, but I think the discussions have been very valuable and informative. And thank those who stuck with us during this recording.